she's from also. Little bit. It first starts from the number. Therefore, full invitation for this. Students step.
Good morning once again. Today, our Honorable Chief Guests are Sri R. Selvam, Speaker of Puducherry Legislative Assembly, inaugurating the function, and then our special guests are Dr. K. Ayyappan, Medical Superintendent of RGGWCH Puducherry. Special invites are Dr. J. Saravanan, Consultant Pediatrician, RGGWCH Puducherry, Dr. T. A. Rosaria, Resident Medical Officer, RGGWCH Puducherry, Dr. S. Guruprasad, Public Relations Officer, RGGWCH Puducherry. The vote of thanks will be given by Dr. P. Punyamurthy, MOT, PhD, Executive Member. And today's sessions will start at 9 p.m. with Dr. K. Satyamurthy, District Psychiatric Government Headquarters Hospital, Cuddalore. And the inauguration function will be start at 10 a.m. And other guests were Dr. J. Saravanan and Dr. D. Dhanasekaran, Dr. Agalya Kandavelu. After our post-lunch, Dr. Shahid Sir and Professor K. Satyamurthy, a distinguished district psychiatrist from Government Headquarters from Cuddalore with more than 20 years of experience. He will be sharing his insights on community-based rehabilitation of a person with mental illness. Sir, the stage is yours.
Very good morning to all. So, at the outset, I would like to thank the organizers and the Association of Occupational Therapists for giving me this wonderful opportunity to talk about community-based rehabilitation of a mentally ill person. Okay, so I will be talking for around 40-45 minutes, and the topic presentation would be like, what is the need for community-based rehabilitation and what exactly the community psychiatry needs, and what are all the stakeholders in this community-based rehabilitation, how it is being implemented through the public-private partnership, and what are all the components of community-based rehabilitation, and what is the future and outcome of the CBR, and very importantly, what are the real scientific, way back to 1950s, there were no scientific treatment for psychiatric patients. Okay, so what they were doing, once they found to have the psychiatric problem or mentally ill, they will be kept in the asylums or in some kind of some protective environment. There were no treatment. They were chained and kept at some isolated places. Okay, and the breakthrough came on 1952. That is the dawn of the tablet chlorpromazine. It was by serendipity that drugs was used for the psychiatric patients. It was a real breakthrough in the treatment of psychiatric illness. After giving this chlorpromazine, thousands and thousands of people become recovered. Okay, so the dawn of deinstitutionalization has started. Okay, that is a real important breakthrough. After the single molecule of chlorpromazine, the patient being into the stream, into the community. Okay, there began the treatment of community practices. Okay. In a country of 1.3 billion people spread across 29 states and 7 union territories, 630 distinctions. Okay, and according to the Smuggler and Thornycroft, the 3 points they are emphasizing is establishing population-based needs. Emphasizing is, one is the resources should be locally individual right to get all the benefits pertaining to the community-based rehabilitations. Okay, access to the community-based rehabilitation, it's a right of the persons to provide for many entitlement which helps in recovery process, especially in the job reservation and as well as in the employment opportunities. Okay, and as per the Mental Health Care Act 2017, the CPR, the person should be accessible and affordable home-based, community-based rehabilitation becomes the rights of the persons with mental illness as per the section 18 of the Mental Health Care Act. So it is very, very clear. Okay, it isn't as per the law, it is individual right of a mentally ill person to get social inclusion, empowerment, and finally so the disability, their families and communities, and a person with a disability often require lifelong management. So it should be the locally accessible with the multi-stakeholders from the community level. So first and foremost thing is the lifelong management, and it should be locally available from the different source of employment or different multi-stakeholders. It also contributes to the prevention of mental health problems and promotes the mental health in the community. Yes, so this is the WHO framing of 5 components put forth in the community-based rehabilitation. One, from the starting from the health, education, livelihood, social inclusion and empowerment. Health, it starts from primary health care, prevention, medical care, and as well as the rehabilitation component. Education, it starts from the early education and college and the higher educations. Livelihood, yes. So after this education, the patient should be developed, or social skill development and the employment opportunity should be created. For that, the skill development is very, very important. And finally, social empowerment and social inclusion in the community. And the last very important component of community-based rehabilitation is the empowerment. Okay, so advocacy and the communication and community mobilization and formation of federation groups in the community or within the family members or between the NGOs. Okay. So, empowerment of people with the disabilities, their family members and communities, which is fundamental for ensuring access to each developmental sector and improving the quality of life and the enjoyment of human rights of the person with a disability forms the final component. And it ensures all the basic rights of human being. Okay? The basic principle of human rights including individual dignity, autonomy, self-determination, equality, ethics of solidarity are central to the community-based rehabilitation. Okay? Yes. So, I need your more attention on this slide. This is the WHO in propagating slide. You can see this pyramid from the apex to the bottom. The bottom is the most the wider need in the community. Okay, that is informal education, IEC, and dissemination of mental health in the community. When you see the apex of the pyramid, that is something like a specialized care, long-term rehabilitation care, which is very lesser in the community and it is more costlier also. Okay, so what we are supposed to focus on from apex to the bottom, from the tertiary care and the hospital, general hospital psychiatry, the next will be the primary health care. There comes the role of the mental health programs, district mental health program. And what we are supposed to focus on the community-based rehab is the base, a typical public-private partnership in the form of empowerment aspects will be taken up by the NGOs. Okay. Yes. So now you can see how the CBR is executed in the community. CBR committee will be formed and the district collector will be the chairman of the committee, and it is integrated with all other departments through the school authorities and education and health and district social welfare officer and district different officer. So it will be integrated along with the participation of NGOs, especially in the empowerment, and advocacy and empowerment is the very important role of the NGOs. Yes. Now comes, I spoke about what is CBR and the multi-state and what are the components of CBR. Do we really need the CBR to be implemented in the community? Do we have any evidences in the community? Yes, we have. What are the studies which supports community-based rehabilitation means? Yes. As per the Asia Pacific Disability Rehabilitation Journal, the programs with the principle based on CBR is known to be highly effective and cost effective. Evidence-based outcome include but not limited to increased independence, and this will increase the greater communication skills of the patients and people with the disability. And as per the Clark et al., livelihood interventions associated with the CBR have resulted in increased income for people with disabilities and their families and are linked to increased self-esteem of an individual. This is a very important point. The self-esteem of the individual is very important in their the disability improvement. Okay, CPR has shown promising results when it comes to positive social outcomes, influencing community attitudes, and to positively enhance social inclusion and adjustment of people with disabilities. And when it started in India, this community-based rehabilitation started by Dr. Vidyasagar in 1950s, and what is the mode he started is not only he treated the patients individually, he invited all the family members and stayed together, and it was the family intervention started in the 1950s. So that was the first community-based rehabilitation started by Dr. Vidyasagar in 1950s. And another approach is 3.5 years multidisciplinary community-based approach study done at Sakalvara rural background, and early identification, free drugs, home visits are followed for early rehabilitation of patients and avoiding the inpatient care. So the motto of the program is, and the people should be reached in the field, it should be identified at the doorsides, drugs will be dispensed, and psychoeducation of the family members, livelihood opportunities should be created, and preventing the inpatient care. It is completely a OPD based care. Okay. Another landmark based approach in India was the Raipur Rani experiment in Haryana by PYAIOTA, and 1981 it involved 60,000 people in this community based rehabilitation. Chatterjee et al. Proved that the study conducted in resource poor setting comparing community care-based approach and facility-based care. They compared the two approach, which is more better, which either it is a community care or facility-based care. The study concluded it was more effective. That is, CCBC plus facility-based care was found to be modestly more effective than only the facility-based care. Another study, it is the longest study in the Indian history. Okay, Chatterjee et al. Used the principles of CPR and developed post-community intervention. The study was conducted for a period of 8 years. The patient was followed for 8 years. Around 256 people of psychotic illnesses, say schizophrenia or bipolar or the psychosis in OS. Okay. After 46 months of follow-up, it shows significant reduction in the disability of all the people with mental illnesses. Okay. Yes. Now comes the very important differences. What is psychiatric rehabilitation? What is psychosocial rehabilitation? Okay. Psychosocial rehabilitation can be done for any kind of calamities, post-tsunami, tsunami, or any cyclone or earthquakes. Okay? But psychiatric rehabilitation is specifically about those who are suffering from psychiatric illnesses, especially major psychiatric illnesses like schizophrenia, bipolar disorders, or dementia-like illnesses. Okay? And as well as the developmental disorders. Yes. Here I would like to highlight how the treatment of psychiatric patients go on. When the patient is started treatment, immediately that you can see the reduction of symptoms. That is called response in the treatment. So three components: response, remission, and recovery we should know in the rehabilitation process. Okay. Moment you start with the drug, the patient will show the reduction of symptoms. That is called response. To maintain in the same remissions, that is called relapse prevention. Ultimately, what is expected out of the treatment is functional recovery process. Functional recovery, that is how the person is able to come back to his normality and for his day-to-day livelihood and day-to-day social activities. That is called functional recovery. The third one requires more time and resources and make it ignored. Okay? So what I am trying to emphasize is the treatment of mental illnesses will not get stopped with pharmacological management. Okay? Without the psychosocial or the psychiatric rehabilitation, the treatment would not be complete in the case of mentally ill. Yes. This slide you can see what are the hurdles a person suffering from mental illness, that is a patient given drugs and he is now symptom reduction is done, and what are the difficulties he is going through from the remission to the recovery. Okay, but when something interrupts in this process, again the patient will get back to the relapse of symptoms. Do you agree? You understand? Okay. So what are all the hurdles is negative symptoms, post-psychotic depression, side effects, stigma in the community, okay, social procrastination even by the family members and by the public, okay, and job opportunities, and financial difficulties, impulsivity, and due to the poor insight of the patients. You know what is insight now? Yes, insight means awareness of self, awareness of one's own illness. That is called insight. The insight will be lacking in the case of persons with mental illness, especially the severe mental illnesses. So when the person is not recovered with the proper insight, he may not understand he is supposed to take the medicine or not. So if he stop taking medicines, again there will be a relapse prevention. in every component of this process, from this remission to the recovery, the community-based, accessible. First and foremost, I think the people should reach the treatment, and after the reaching of the treatment, it should be continuously, it should be accessible to the people. So what is the way forward? For a population of 140 crore, not a single or a private sector or one department or one institute can deliver 1982, and it came into existence by 1996 only. Okay, and it is a pride and proud moment to express you that Tamil Nadu is the only state which covered all the 38 districts under the district mental health program. Okay, currently in India, around 670 districts covered under the district mental health program, which is almost 85% of all the districts of India is being covered under the district mental health program. So what is the need? Yes, to make the treatment accessible, and it should be continuous. Then only we can reduce the psychiatric morbidity of the persons suffering from the mentally ill. Okay, so emphasis on identification and initiation of treatment at all level hospitals, and especially at the primary health care level. Okay, you have a PSCs, yes. You have a primary health centers, yes. So the mental health should get integrated into the primary health care. That is a very important component. Okay, ensuring the continuity of care becomes critical and part of the rehabilitation. Yes, so these are the objectives of the National Mental Health Program, to ensure the availability, accessibility of mental health for all in the foreseeable future, and encourage the application of mental health knowledge in the community, and promote community participation in the mental health services development, and stimulate self-help group in the community. Okay. What are the components of district mental health program? Number one, service provision, capacity building, and awareness generation activities. Service provision, yes, early. Yes. So what mental health program? It doesn't stop with that empowering the students, especially for the psychological well-being. So the program addresses and the target of people, and identify the peer ambassador in the colleges. So they will be the peer person to identify any issues in the school or colleges. So that is called Manam program. And workplace stress management, suicide prevention services, and rehabilitation activities. So this is one of the outreach activity. It is the district mental health program of Kadalur district. Training of the PSC doctors and training of the NCD staff nurses or CH care. Periodically, nursing and paramedical people will be trained in the mental health care. Yes. Anganwadi workers, VHNs, village health nurses, being given the 1 day, a short mental health training. Okay, October 10th is the World Mental Health Day. September 10th is the Suicide Prevention Day. And life skills training program, and we conducted training for the trainers. So we invite the teachers from all the sections, and they will be given the 3 days training of the life skills educations. They will be the master trainers, and they will inculcate the same thing to the students level. World Suicide Prevention Day activities. What are all the things which I am discussing is the service component of the district mental health program. Suicide prevention activity at the prison, yes. And very important suicide prevention activity is going on in the state of Tamil Nadu. What is the SOP we are following, in the district headquarters hospitals? Those persons coming for admission, especially attempted suicide or any form of suicides, after the acute phase, the patient will be screened at the bedside and they will be referred to the psychiatric OPD and complete assessment will be done. And before the psychological evaluations, patient will not be discharged from the hospital. This is the SOP we are following for more than 10 years. And after the discharge, with the proper consent form from the clients, the consent form is uploaded to the state NHM level and they will be following the same attempters for the chain the patients and kept the patient in the places. What we do is periodically we go and sensitize the authorities not to chain, and there should be any inhuman activities for the mentally ill persons and talking to the family members. So after the regular instruction and sensitization to the authorities, what happened, love? So whoever come to the dargah, they will immediately send back to our OPD for our registrations. Okay? So concurrently what they will do, they get the treatment as well as they will go for their belief systems. Okay, they worship and they pujas, they will be. So we are not opposing their belief systems. So scientific based treatment should be there and there shouldn't be any inhuman treatment to the persons affected with mental illness, as well as their sentiments, their belief system should be go on. Okay? Yes. The very important project in the process of CBR is started, like Government of Tamil Nadu started a home for mentally ill, that is around 10 homes through the state. Initially it was started for 3 districts, 1 home in common it was started. Okay. This home is mainly for rescue operation of the wandering mentally ill. Rescue operation of the wandering mentally ill. For your kind information, after the rescue, what we do, we treat the patient and daily vocational training is being given. After the process of the recovery, and we got the different persons from the different states, Bihar, Jharkhand, Kashmir, all the states of the people being into the streets, and we recovered, we rescued and treated the patients. Currently, for your information, my dear friends, so far in this Cuddalore district, we have rescued and treated and rehabilitated around 500 people from the streets. And for your information, among the 500, so far we have reunited around 300 people into the family members. Okay, this is for your kind information. So rescue, immediately the treatment process being started, and after the recovery, this patient is from Kashmir. Okay, so recovered individual, we trace the address of the individual, and the person has been reunited in presence of the district collector. And one more process we integrate with the one foundation called Shraddha. Around 23 years they are doing the same process, that they collect the recovered individual and reunited with the family about to deliver, and we used to certify for the mental retardation, autism, SLD, as well as for the mentally ill. And what are the benefits means travel concessions, okay, and railway concessions, and monthly grant of 1,500 for the mental retardation, 1,000 rupees for the mentally ill, and finally they are given the 4% job opportunities. In Tamil Nadu, the reservation percentage for the disability is 4%. Okay, once if the person is given the certification and the ID card, they are eligible for employment in that category. Yes, these are the schemes in the past involved with the CBR, with the district mental health program, வாழ்ந்து காட்டுவோம், புதுவாழ்வு மனநல திட்டம், community mental health project, and ECRC, okay, emergency care and recovery center, which is started exclusively by the government as well as in participation of the NGO. So we have around 6 NGOs, six ECRC functioning in the state of Tamil Nadu. And finally, very recently, the most expected project of pertaining to the CPR is a rights project implemented in the government of through the government of Tamil Nadu by the Department of Rehabilitation. Okay, so I was talking about the 5 components, health, education, livelihood, and social integration and empowerment. So the rights project is implemented through the district rehabilitation department, and the components which we had discussed it is into the process. Now it is into the practical situations. Currently around 16 districts of Tamil Nadu covered in the rights project. Okay, and very soon all the 30 districts will be covered under the rights project. Okay, so need to improve mental health care delivery, restructure medical and nursing education into the skill-based courses, revamping the psychiatric training especially, and political will is very important. Nowadays, the awareness in the media and all the aspects, especially the mental health awareness, is really good in all sorts of social media, and wrong propagation should be avoided. Okay, there should be a stringent law in preventing such things. So how we maintain the censors in the film. So similar things should be put up in the social media in avoiding the wrong news about the mental health, and bridging community psychiatry and the social preventive medicine, and definitely there should be a public-private model and involving the traditional health healers and the community-based healers in the community. Conclusion: community care persons with mental illness has moved a long way from institution to community setting, and district mental health program promises to ease access to the mental care without any discrimination, and realized into action, it will reduce the disability, reduce family distress and burden and stigma in the community. Finally, it will integrate with the primary health care and realizes the vision of health as a fundamental right of every citizen of the country. Okay, so I stop here. Thank you so much for this wonderful listening. I am happy to answer any sort of questions related to this topic.
Any questions? No other queries? Thank you, sir, for your insightful session on community-based rehabilitation of a person with mental illness. Your expertise and valuable perspectives have shed light on the importance of community-driven approaches in mental health rehabilitation. We truly appreciate your time and effort in sharing this knowledge with us today. We would like to call Dr. Inamaragan to facilitate our speaker. We would like to call Dr. to give a token of appreciation.
The profession has started in England and France, and then it was carried over to US. We have almost completed this into the society. I think it was a very career and collaborate with such programs in future. Thank you very much.
We will also welcome our special guest, Dr. K. Iyer, Medical Superintendent of RGGWCH, to the stage.
चार ड्रैगन बोलना
Yeah.
requesting you all to stand for Samurai violence. Thank you all. Now I would like to invite Dr. R. Inavarakal to deliver the welcome address to our esteemed chief guest and our special guest.
Good morning to one and all. Today, it's my pleasure to welcome our Honorable Chief Guest, Selvam, Speaker of Puducherry Legislative Assembly, who is inaugurating.
We are delighted to extend a warm welcome and present a token of appreciation to our esteemed chief guest, the R. Selvam, Speaker of Puducherry Legislative Assembly.
வெறிச்சோடி மனநல மையத்தின் சார்பாக இன்றைக்கு மாற்றுத்திறனாளிகளான ஒரு நாள் மருத்துவ பயிற்சி முகாம் விழாவிற்கு சிறப்பான முறையில் என்னோடு கலந்து கொண்டிருக்கின்ற இந்த மருத்துவமனையுடைய மெடிக்கல் சூப்பர் டாக்டர் அருண்சோதரர் ஐயப்பன் அவர்களே, சிறப்பு விருதுகளாக வந்திருக்கின்ற சரவணன் அவர்களே, வரவேற்புரை அமர்ந்திருக்கின்ற இளவழகன் அவர்களே மற்றும் இந்த நிகழ்வை கலந்து கொண்டிருக்கின்ற அத்தனை மருத்துவத்துறை சார்ந்த மருத்துவ அதிகாரிகள், இந்த பயிற்சியில் பங்கெடுத்திருக்கின்ற அந்த பயிற்சி அளிக்கின்ற தருணத்தில் அவர்கள் செய்கின்ற பல்வேறு இடர்பாடுகள் எல்லாம் தாங்கிக் கொண்டு அவருக்கு பயிற்சி அளிக்கின்ற பொழுது அவ்வளவு உதவிகளை செய்ய நீங்கள் பயிற்சி பெற வேண்டும். அதற்கான வழிமுறைகள் எல்லாம் இங்கே இருக்கின்ற மிக சிறந்த மருத்துவர் எங்கள் ஐயப்பன் அவர்கள், சரவணன் அவர்கள், ரசாரியா அவர்கள், குரு பிரசாத் அவர்கள் ஆக இது போன்று பல்வேறு மருத்துவர்கள் தெரியாத மனநிலை அவர்கள் இருப்பார்கள். அப்படி அளிக்கின்ற பொழுது அதனால் ஏற்படுகின்ற அவர் செய்கின்ற பல்வேறு விதமான கஷ்டங்களை தாங்கிக் கொண்டு அவருக்கு பயிற்சி அளிக்க அவருடைய மருத்துவர்கள் போகும்போது ஸ்டெத்தஸ்கோப் வச்சு பார்ப்பாங்க, உடனே சிட்டையில் போய் பார்க்கணும். அது போன்று இல்லாமல் மருத்துவத்துறையிலே கனிவோடு அது மக்களுக்கு எடுத்து சொல்கின்ற போது அவர்கள் சொல்கின்ற விதத்திலே பாதி உருவாகிவிடும். அது போன்று மருத்துவத்தை எல்லாம் பயன்படுத்தும் ஒரு மருத்துவர்களாக இன்றைக்கு இங்கே இருக்கின்ற அத்தனை மருத்துவர்கள் இருக்காங்கன்னு நினைக்கிறேன். ஆனால் ஐயப்பன் சார் பற்றி தான் தெரியும், மீதி தெரியாவிட்டாலும் கூட இந்த அல்ல குறிப்பாக அந்த குழந்தை மருத்துவமனையில் இருக்கின்ற அந்த மருத்துவம்லாம் ரொம்ப ஈஸியாக, ஏன்னா எவ்வளோ கஷ்டம் தாக்கி மருத்துவ படிக்கிறோம் என்று தெரியும். அதையெல்லாம் தாங்கி கொண்டு இந்த மருத்துவ சேவைக்கு பணிபுரிகின்ற அவர்களை வைத்து இந்த பயிற்சியை நம்முடைய இளவரன் அவர்கள் வந்து உங்கள்கிட்ட கொடுக்குறாரு. இந்த பயிற்சியை பயன்படுத்தி நம்மால் முடிந்த அளவுக்கு இந்த மாற்றுத்திறனாளிகளுக்கு உதவி செய்ய வேண்டும் என்று வேண்டுகோள் வைத்து இந்த பயிற்சி முறை எங்களை அழைத்து துவக்கி வைத்த அத்தனை நல்லுறவர்களுக்கும் என்னுடைய வாழ்த்துக்களை பாராட்டும்படி சொல்லி விடைபெறுகிறேன். நன்றி, வணக்கம்.
now have a session on a critical role of early intervention in pediatric care, a key factor in shaping long-term health outcome for children. We are honored to welcome Dr. J. Saravanan, a distinguished consultant pediatrician from Rajiv Gandhi Government Women's and Children's Hospital. With his vast expertise in pediatric medicine, he has been instrumental in advocating for and implicating early intervention strategies to ensure a brighter future for young patients. Today, we will be presenting on Early Start, Bright Future for Early Intervention, highlighting the importance of timely diagnosis and intervention in pediatric healthcare. Sir, we are delighted to have you with us. The stage is yours.
Thank you. Thank you for your good introduction. I think I had a very difficult task of holding you before a tea break. I don't want to bore you. And my topic is to tell you the importance of early intervention, early start, great future. I think everyone is aware of this and not that anything new about it. But what I want to share with you is a pediatrician perspective of we run the medical law. That was one of the proposed theory where it was well accepted. Theories are theories unless it is proved negative. It's a theory. Nobody has proved it negative law. So it was one of accepted theory. According to that, life has started to work. Due to some reason, particles stick together and to stay together, some cell membrane started. And they started to have some specialized organs. The cells just saved the multicellular organism. They started the multicellular organism. And they had a systemic function. So this is how the evolution started from unicellular organism to multicellular organism. And we are here with the evolved stage. So as per this evolution theories, these changes has happened over a period of thousands and thousands of years, maybe crores of years, we don't know. But one beautiful thing that we can observe is that we can observe the same type of evolution changes in the developing womb, inside the mother's uterus. That's growth considered a sperm and ovum will together form a zygote. The zygote will form a multicellular embryo. To form an organ. So when you say there is a life in that embryo, and somebody to say there is a life in the embryo, sure it's very common to say you be done now. Say that you are pregnant, but nobody says there is a life inside the embryo till you have a heartbeat scene. A heartbeat controller, scan the father, he accepts that there is a life. That doesn't mean there is no life before that. There is life before that. But our science can identify the life only at the point of time. That is the only perception available till now. So maybe 6th or 10th week, you can appreciate the beating heart. And maybe after the 3rd month, 4th month, other systems will start growing slowly. So at that point of time, the baby does not need any lungs to get the oxygen to survive. And oxygen on the provided in the mother's blood. Baby does not need any nutrition from the gut. So even though it is not needed, the baby starts developing all those organs. So the baby is preparing for the delivery. Delivery is doing all those necessary arrangements, all those rehearsals are being done for that one time delivery. So by around 4th month, 5th month, the baby can have differentiated organs. Central nervous system will be there, CVS will be there, gastrointestinal system will be there. கொஞ்சம் உரைக்காம நம்ம படிக்கிற தியரி எல்லாம் வேணும். Start from pressure to tension. Baby will have reflex, will start cooking. The baby will start taking some breaths. மூச்சு எடுக்க ஆரம்பிக்கும். Definitely mother will come and say, keep on the corner. So அப்பா வந்து அந்த breath-ஓ the kick-ஓ that's not necessary for the survival of the baby. The baby does not need those breaths or those kicks. But these are occasional trials
the respiration for a while, swallows the fluid, open the glottis, and again the baby will reinstate the respiration. That's some of the complex process. That cannot be done at the stage of 32 weeks. Around 32 weeks to 34 weeks, 8 months, so we always feel that any baby before 32 to 34 weeks, the world was sustained our qualities. Most of the babies need support at that time. So initial support will be provided by the pediatrician at the delivery, and after that the baby should be sent to the support from the miracle matters. Okay, so by around 34 weeks, baby will be having a mature respiratory center. Baby can swallow normally. Baby can stop the respiration. Baby can reinstate the respiration. Can have a continuous breathing heart. So the baby will have all the qualities to survive in the world. So obviously the fine day will come. The baby will be delivered to the world. So obviously for a nalla warmer, nalla AC, or nalla warm from the baby will come. We might not like the one only like the one. So the baby will try and close the eyes. The baby will think that I can go back into the room or right. Okay. So what baby is delivered, baby will start crying, already the baby has taken so much of rehearsal to eat and drink. Baby has taken so much of rehearsal to kick. Baby has taken so much of rehearsal to swallow. So the world of the baby can survive forever, for some time. But how long the baby can survive like that? So the evaluation has to go on. So for another 3 months, 4 months, the baby has to change and adapt to the world. Initially the world will be cold, it will be very cold, sometimes it will be very warm. The baby has to adapt to the environment. The bright light will not be acceptable for the baby because the dress is a nice, comfortable place. So the baby is surviving on the 6th week, 8th week. So baby will try to understand that there is no possibility of getting back to home driving. It's not possible. So they have to survive. So anymore the baby will not close the eyes. Baby will open the eyes and see. The baby might not like everything what they see. Upon the baby or vision that the things but the baby or work. So the baby or vision will be around some 50 to 60 degrees. The baby will take the mother's milk, Allah solve the they will sleep. That the baby will go. So by around 8 the week, so once the whole should attract people and get things done, the baby will try to ask for the feet. It will look at everyone who is coming near the baby. The baby will try to attract them for the care. They will laugh at them. They will try to connect with them. They will try to enjoy the face by around social smile on the social. So, like on the particular state where the baby will have a vision will be around 50 to 60 degree will be there. So, in the eye or vision, this side will have a separate vision. So, 2 types of images will be formed. As you all know that 2 types of images will be processed in the brain by the nerve. So initial of the baby will have a uniocular vision where around 3rd month, 4th month. The baby will try to process both the images. The baby will try to form a 3-dimensional image. So around 3rd month or 4th month, the baby can have a binocular vision with perception of depth, height, distance. It is one of the very critical process of development of the vision. So this is one of the very critical process of development of the vision. So why do you want to highlight this type of critical processing of vision? See, like you would have come across some babies with congenital cataract, some babies with defects in the vision. You would have come across some babies like that. So if you are going to operate on that eye, and even if you are going to restore the vision in that particular eye, that particular eye was already neglected. So I don't want that eye anymore. So I don't want that eye. Okay, eye is anatomically normal, functionally normal, but I don't need that I anymore. So whatever correction you do is useless for them. Okay? So that is the one of the very important point of early identification of congenital care. So that's the early. By 4th month, 5th month, where we can look around. Okay, so when we talk about the field of vision will enlarge, first of 180 degrees. Okay, maybe we will track all the objects. They will laugh at them at the same time. So at the same time, maybe we will be having and the flexure law happens to the extension, they will get into extension posture. They will start kicking. So I enjoy the climate now. I don't want that font now. And I purpose to so I get into the extended posture. I started kicking. I started schooling to attract my standards. I started smiling. This happens around 4 to 5 days. So if they are going to so I have I try to feed with the hand. So because baby start feeding, whatever the oil will come, so all the saliva will start coming down. That's what we say finger feeding. It will happen around 5 days. So meanwhile, proper direction growth they will try to roll over and control will come. They will try to roll over. Okay. So when they have control over the head, they can turn the head. Still their field of vision is now enlarged. They can roll over. Now their field, the body will roll over. Whatever I can see is my world. If something is removed from my vision, it is not in my vision. So I can move around in the hall. And according to me, on the hall, I don't know. According to me, I don't have any other word apart from the hall. Where around 7th month they can sit comfortable upon the floor, they can pivot. So almost 360 degree they can watch. They can watch 360 degree. So anything is there in their vision is their world. So the world they might not understand it. Okay? They would have seen that baby have a anxiety and cry and the baby is removed from their world, other okay. So other than that, when they are crawling, you can see them having a farmer grass inside farmer. So the basic instinct is to feed them. They will try to keep everything into the mouth, not a mouth. So initially they have fruit grass, or piece of grass for farmer. So everything is towards one particular point of survival. Everything is towards one particular point of survival. So I am trying to feed myself. I am trying to pacify myself. I am trying to survive. So by around 7th or 8th month, I can take things. I can feed myself. I can finger feed myself. So the things the 9th, 10th month, I can just take it, keep it. So occasionally, the baby can drop something from their hand. They can drop something. And they will see that things are vanishing. They will take something, some objects will be taken. They will just drop it. They will think that things are vanishing. Turn up it. So we will go and play with the baby that things are vanishing. Kaga, we will play with them. We will tell them, the baby will understand it's vanishing. So it is not in my world. So it happened for a while. What will happen? We will try to drop it again and again. It does an experiment again and again to see whether it is vanishing. So every time you give and see anything to your baby with knife and they will try to throw them and see whether it is vanishing. You always call them casting. We call them casting. So I do that natural experiment again and again to see whether things are vanishing. At some point of time, I understand things are not going to vanish. Things are not going to vanish. I am going to throw something, it is going to lie somewhere there. And again I will do it. I try to throw it, it is going to lie somewhere. So things are not going to vanish. Things will never vanish. So I understand things are permanent. Okay? That's one of the very important milestones that we are watching for. So we call it object permanence. Okay? Once I understand things are permanent, things are not going to vanish. So permanent we try to ask for it. We try to ask for everything. So you can see any baby by around 10th month or 9th month asking for things. You try to point to the objects. You try to point to the objects and say, I want it. We call it properly generated mind. So these are very, very important milestones to understand how the world of the baby evolves. So by around 9th month, 10th month, the baby understands things are very, very permanent. Objects are not going to vanish. So I can ask for it. I can just point and ask for it. I can declare to you that I want that object. I'm going to go away now. That is one very, very particular important milestone to understand very, very basic concepts of objects. Okay. So once the baby understands that things are very, very permanent, things are not going to vanish, you cannot cheat the baby. You just try to cheat them, they will come and search for it. They will play a peekaboo. You try to hide them, they will come and search for it. We try to do the same milestones for the babies. So, like, till that particular 11th month, 10th month, the baby understands that things are not vanishing. The baby will have an anxiety that when mother is removed from the field of the vision, the baby will have a very, very anxiety. Okay? So, the stage of anxiety will go and slowly they will go for a real world scenario. So, this particular development milestone we are very much interested in. Maybe connected to the real world. That's what you are all doing. So, if you miss that milestone, that's one of the missed opportunity to get them connected to the real world. They are coming back by 1.5 years, 2 years. The baby is not talking. The baby is not listening to you. The baby is simply playing and throwing objects. The baby is sitting and having some object and that's very late. They can do very little and the outcome will be guarded. So if you understand these concepts of play model of identifying these problems, it will be very, very, very easy to pick up these developmental issues and give a therapeutic intervention. So like, and again, like regarding the stages of development, the stages develop as I told you before the conception. So before the conception, where we can give some input to the mothers, so antenatal care is given so that the mother is healthy, the babies are having very good growth. Then comes the birth and infancy and childhood, the process, the 4 stages. Okay. The next early identification idea is how we look for the cataract, we look for the retina. You are all aware of it. And one more very important thing that we want to look for is the development of teeth. Most of the babies who are going to come back by around 1 year, the company has to look for it and make sure that the head of the femur is inside the acetabulum cavity. Okay. If any problem is found, the measures are taken to keep the head of the femur inside the acetabulum cavity. So you might come across any baby by around 3rd month or 4th month, not crawling. So just kindly look for it. Because they are going to identify these problems at the time of delivery or at the time of birth or at the time of first month of baby. Our aim is to keep the femoral head inside the acetabulum cavity. It can be done very, very simply by putting one more extra pancreas to keep the legs putting one more extra pancreas by a speech and I can have an harness and ask the mother to keep the baby inside. It's one of the easiest intervention that you can do. To miss that particular opportunity to experiment these babies at that time. So maybe the acetabulum cavity is very, very shallow. Then the neck of the femur is out of the acetabulum cavity. So the neck, the head has got crumpled. So obviously, the head is there. So obviously the baby has to go for an entire. So I personally believe a lot of miracles happen. It's up to you to identify all these problems at the earliest as possible and you can make some miracles happen in somebody's life. I think you are all aware of all these things. We will not tell everything more. continuous and progressive process, it is having a different perspective. So many other factors has to be taken into consideration before filling the baby up now. As I told, that early intervention is the key, and it is going to hold a very important role in outcome of the baby. Just I want to share how it is being done in Puducherry. Okay. So Honorable Puducherry is one of the central sponsored schemes. So it is implemented through RPSK. And every baby delivered has to be delivered in a hospital. It is one of the policies of the government. Baby has to be delivered only in the hospital. And a trained doctor or a trained health person should screen the baby. So somebody has to be there to assist the baby to survey the body. So initially, medical support, whatever is needed for taking the first breath, for taking the first speed, for taking first small things, the health will be given. And then the baby will be screened for the all visible health defects, whatever it goes on, like annual cataract, annual dislocation of the hip. Now all other annual problems will be screened at the time of delivery. So after delivery, the baby will be discharged, baby will be going to the mother's home. So ASHA workers who are visiting the maternal home, they will just have a look at the baby. So normally they will go to Anganwadi, and Anganwadi they will be seen by our own doctors. And again they will go to the school, they will be seen by the same mobile when they will see the school children. So any problems identified at that particular point of time, they will be referred back to the district early intervention center. Here the district early intervention center acts as the hub model. So any baby having any problem in development or congenital defect or whatever it is, the baby will be referred to the district early intervention center. The district early intervention center is going to function in all the district health hospital or district headquarters hospital. With the facilities of handling the baby's small problems like a pediatrician will be there, a dentist will be there, an optometrist will be there. So you will have a facility to have a consultation for ophthalmology, psychiatrist will be there, child psychologist will complete their therapy without interruption, so the outcome are very good. So for Puducherry, EAC is functioning in the third floor, Rajiv Gandhi Children's Hospital. We have a very good team of doctors, staff, therapists there, attending to the needs of the children. So as you know that the number of kids are rising, we are engaging other NGOs for therapies also. This is how the study is being implemented. Okay. Thank you. We're happy to answer any of the questions. Is not on single region, it is almost there everywhere in Andhra Pradesh, in small quantities here, something there in Kerala, and then Karnataka. So there are pieces of land everywhere, and we are dependent on surrounding areas also. So we cannot set up a separate DAC for knowledge. We are dependent on nearby DACs there in Kerala, and we are dependent on nearby DACs there. Any other major surgeries, like for example, like any child was found to have some congenital deafness, so we have a separate program to screen all the babies delivered in Rajiv Gandhi Puducherry for congenital deafness. So every baby has to undergo the screening process, and they should have the report with them before they are being discharged. They discharge only with the screening card. Another photo. So we have started the calculator program in Puducherry also. The idea is to catch them early. It was done in the first year of the life. Most of the therapy problems that you face will be like long implant was done earlier, almost the therapy will be more easier. So that is one thing that was launched here. Unless in the very tertiary care procedures, we are trying to address those areas in the nearby age. So if it is a specified surgery needed, like something like congenital heart disease, cochlear implant, or neural defects, or something like that, neglected health. So those surgeries are being arranged in nearby hospitals. We are trying to connect with ISMA, and EGH, and government is having an MOU with WHL hospitals for congenital heart disease. So like for tertiary care, we are dependent on the regional institutes and private institutions. But for other therapy needs, where they have to visit the institution again and again, they have to go to the institute for more than 2 days in a week. It doesn't think it's possible to get them to this area or to have a separate team there. So the better idea is to have a connected hospital infrastructure there by the nearby area. I think they are doing a very good job in Kerala.
Has reinforced the importance of early diagnosis and protective care in pediatric health, ensuring better outcome for children. We truly appreciate your time and valuable contribution to this week. We would like to extend a warm honor to our speaker. The session is about to start. I'll ask you please maintain silence.
I request everyone to come inside. The session is to start. The next speaker has commitment. Today is Sunday. Please understand and come inside. Before we start the next session, I would request, may I have your attention please? Before we start the next session, I would request you to keep, during the session, please keep silence. It's very annoying and disturbing. It's a very difficult task, I understand. To maintain silence is a very difficult task, but you have to accept it. All you have to do is, when one person is asking you something, do not respond. And if you are asking something, just ask yourself, is it that important to ask him now itself during the session? That's it. And if somebody has by chance asked you, you do not have to respond to that. It's very annoying to the speaker who is present here. Okay? So please follow that and do not disturb the sessions when they are going on. Thank you.
Prefer to have a vegetarian meal. Please raise your hand who all prefer to have a vegetarian meal. Only 4 members? Okay, thank you. Thank you for your cooperation. Moving forward, we have an insightful session on traumatic brain injury, a condition that requires precise medical intervention and rehabilitation strategies. It is our privilege to welcome Dr. D. Chandrasekharan, a highly esteemed consultant neurosurgeon at government hospitals. With his vast experience in neurosurgery, he has been instrumental in advancing treatment for brain injuries. Today he will be sharing his expertise on recent trends in TBI from injury recovery, shedding light on the latest in advancements in TBI management and rehabilitation. Sir, we are honored to have you with us. The stage is yours.
Good morning to all. Now to talk here about the day by day the head injury and road traffic accident and death is increasing the side. So this is the state-wide distribution of the fatality rate. So each state is telling nearly 15 to 60 times per 100 cases of the RTE. And Tamil Nadu Pondicherry is the highest number. So these are the how the accidents happen. It is more on two-wheeler because of the we don't for the road safety, as well as we won't wear the helmet, we won't obey the traffic rules, we will always use a cell phone, we will drink and drive also, we will have the over speed also. So most of the injury by the two-wheelers accident and 17% the pedestrian nothing but not the corona. Walking. Car is 6%. 60%, that is also drunk and drive and not wearing seat belt. Then 10% drug here, much more salary, and this is the productive time of the life. We are losing the prime time and prime person in this 25 to 35 age group. So you see see the graph, below 8 means it is less than 10,000 and 18 to 25 is 35, but 25 to 35 is 48,000. And after 6 years it is very less, because after 6 years no one will go drive the two-wheeler and no one will go out of the home, very rarely. After 6 years of the earth, they will have self-fall in the home, in the bathroom. You see this also, so more than 86% is a male. Okay. Because safety. So female drive towards very less. Those who are working and those who are studying, most of them will go with the common way to the bus and transportation. See, you see the incidence from 2016 to gradual increase. See, the 2020 and 21 is lockdown. That's why the peak is very low. Because of the lockdown, the road traffic has come down, and after 2022 it is gradually increasing. You see it is India statistics. All over the India, we have 4,43,000 of road traffic accidents. Out of that, we have 1,68,500 passengers died. That is an alarming figure. You never ever imagine this much of death has happened in 2022 because of only road traffic accidents. This much increase in number of the two-wheelers caught a little bit. This is urban and rural. Every time I locked up, now in the car. Brain. Okay, it's brain. What is the white color in the right side? Hemorrhage. Very good. This is called extradural hemorrhage. Okay. So what happens when right side injury? What happens clinically? Patient will what will have? Very good. Left side. He will have left side paralysis. That means so the kind of அசைக்க முடியாது அவரால. சரி, right side left side இடது கையை கால் அசைக்க முடியாது. இது இன்னும் கொஞ்சம் பெருசாச்சுனா கோமா ஸ்டேஜுக்கு போயிடுவாரு. சோ இதுக்கு என்ன ஃபர்ஸ்ட் ரெக்வெஸ்ட் வந்து என்ன எப்படி மேனேஜ் பண்ணுவீங்க? ABC protocol தெரியுமா? ABC protocol. Airway, breathing, circulation. So then we will have to get into it. That we don't know. We expect we don't know also, but we will give antibiotic, anti-epileptic, and analgesic. And we have to do surgery, like we have to do craniotomy and evacuation. If this case is right side, if it is present left side, patient what will have? The hematoma left side is not enough patient. Right side patient கூட என்ன இருக்கும்? MPT இருக்கீங்களா? MPT ஆகுது. Left side patient இருந்துச்சுன்னா பேஷண்ட்டுக்கு வந்து ரைட் சைடு ஹெவி பேரலிசிஸ் இருக்கும், கூடவே அபேசியா இருக்கும், பேச மாட்டாங்க. Because we won't go to the detail. We will mild, moderate, severe. 30 to 15 mild, 8 to 20 is moderate, less than 7 is severe. Okay. For that, this patient will undergo this is decompressive craniotomy and evacuation by SDH, subdural hemorrhage evacuation. இது என்ன தெரியுதா? என்ன ஆயிருக்கு பாத்தீங்களா? Fracture. Suppose நடு தண்டு வந்து இது போடுது. இவருக்கு என்ன இருக்கும்? இந்த பேஷண்ட்டுக்கு என்ன ஃபைண்டிங்ஸ் இருக்கும்? Paraplegia, very good. Paraplegia கூட என்ன இருக்கும்? Very good. Blood and bowel incontinence. So, sensation இருக்காது. That means T10 ஆச்சுனா umbilicus கீழ sensation எதுவுமே இருக்காது பேஷண்ட்டுக்கு, complete paraplegia, and patient will have bladder bowel incontinence. So இது மாதிரி கேஸ் தான் the physiotherapist rehabilitation will come into the part. That will be taken next session. Okay. after the session, you should know what is the immediate late complication of the neurospine trauma. அதாவது தலையில் அடிப்பட்டவங்களுக்கும் ஸ்பைனல் அடிப்பட்டவங்களுக்கும் இமிடியேட் லேட் காம்ப்ளிகேஷன் என்னன்னு தெரியணும். ஓகேவா? What is neuro rehabilitation? Role of neuro rehabilitation. How to improve the physical activity fitness level. How to maintain the physical activity fitness. Okay. Next slide, please. Okay. What is neuro rehabilitation? An active process by which those disabled by the injury or disease achieve full recovery, or when full recovery is not possible, realize their optimal physical, mental and social potential are integrated into the most appropriate environment. We cannot put it. You try to achieve full recovery. If full recovery is not possible, என்ன வருதோ அதை கரெக்டா பண்ணுவீங்க. ஓகேவா? What's the aim? To maximize the independence and functional potential, minimize the secondary complication, minimize the restriction limitation, remove the environmental barriers and provide facilities. Okay. What is the secondary complication when patient is having prolonged bedridden and spine trauma or brain trauma in coma stage and ventilator? What are the complications you are expecting? Very good. So, DVT, deep vein thrombosis. Very good. Contraction, spasticity, heteropic ossification. That will see. Okay, that's it. See, DVT, spasticity, rigidity, heteropic ossification, speech, swallowing difficulty. That is why you will put rise to for the all hereditary patients. Mobility, independence in the daily activities, cognition, communication. That cognition, communication, higher order functions that will be dealt with later. This is the ankle contracture. This is the heteropic ossification. This is the pelvic heteropic physiotherapist or occupational therapist or doctor therapist, speech therapist, finally family also. So these are the combined process to have the better neuro rehabilitation. So these varieties of the programs for the post-acute and long-term complication, brain injury with other conditions, behavior management of specialized problems. For example, he is having aphasia or he is having right monoplegia. So for that you should have specialized program for that. Severe and moderate behavioral problems, pediatric programs, further intensive rehabilitation integrated into structured education program, like previous speaker told. Day rehabilitation, home health services. Okay, now we will go to the each complication one by one. What is contracture? The joint will be normal. Any degree of loss in joint ROM, that is range of movement, due to changes in passive mechanical properties of the soft tissue planning joints. So how to prevent the contracture? Contracture excess கொடுத்திருக்கீங்களா நீங்க இதுக்கு முன்னாடி? Patient should have proper positioning, proper sprinting, prolonged gentle strengthening exercise, joint range of motions. This is proper position. Definition is proper positioning in the physiotherapy means placing the patient body in a way that evenly distribute their weight, minimize the strain on unaffected areas, and promotes the optimal arrangement to facilitate treatment and prevent the further injury. All bedridden patients will have all air bed. And then for ankle contracture we will have this sandbag. For the forearm contracture we will have the arm splint. For lower limb contracture also lower limb splint will be there. If you won't do anything like example bed sore for the upper bed as well as upper limb splint, now patient will have the contracture bed sore pressures or everything. Sprinting. Sprinting is a rigid device used in the physiotherapy to immobilize the body so it can heal. Sprints are often used to treat the injuries such as sprains, fracture, burns, as well as conditions that affect the muscle or joints. These are the various upper limb sprints to prevent the contracture, wrist, elbow, as well as finger. Okay. Next, we'll go for the prolonged bedridden and ventilator associated complication. What are the respiratory complications you can think for the prolonged ventilator patient? ஒரு பேஷண்ட் ஒரு வாரம் வென்டிலேட்டர் இருந்தா என்னென்ன பிரச்சனை வரும் எதிர்பார்க்குறீங்க நீங்க? பிசியோதெரபி ஆக்சுவலா வந்து 4 பாயிண்ட்ல முடிஞ்சிடும். கண்ட்ராக்சர் அவாய்ட் பண்றது, ஸ்பாஸ்டிசிட்டி அவாய்ட் பண்றது, ரெஸ்பிரேட்டரி பிசியோதெரபி, பெட் சோர் அவாய்ட் பண்றது, தென் ரீஹபிலிட்டேஷன் முடிஞ்சிடும். வென்டிலேட்டர் இருக்க பேஷண்ட்டுக்கு எப்படி நீங்க பிசியோதெரபி கொடுப்பீங்க? எதுக்காக கொடுக்கணும்? First பேஷண்ட்டுக்கு வந்து பேசல் ஸ்டாட்டிக் நிமோனியா வரும் because of the prolonged bedridden and immobilization. அதுக்கு அடுத்தது பேஷண்ட் சரியா போச்சுன்னா உங்களுக்கு வந்து இன்டர்காஸ்டல் மசில்ஸ் பேரலிசிஸ், வைட்டல் கெப்பாசிட்டி எல்லாம் ரெடியூஸ் ஆகுது. இது கூட என்னென்ன அசோசியேட் ஃபேக்டர்ஸ் பாருங்க. Because of the effective positive pressure ventilation and a low conscious level, sometimes fracture ribs to have the less mobile, brainstem injury and impaired mucociliary function mobility. Brainstem injury, how it affects the respiratory secretion? When you are coughing, when you are taking sputum out, the brainstem should intact. Brainstem injury patient will have swallowing as well as cough reflex will be down or absent. That is the reason why all patients with brainstem injury frequent to aspirate and then they will have the aspiration pneumonia. So how to prevent the respiratory complication? To prevent the respiratory complication from the developing or mitigate the already developed problems. To promote the airway secretion clearance. Maintenance or improvement of the lung volume, optimization of the oxygen, maintenance or training the inspiratory muscle strengthening. This is what the respiratory exercise. Next. So this is how we have to do the sun. We have to do tapping method. I think you know, somebody will know what's tapping method. Posture drainage modified. You should not do the head tilt down pushing a bed. It's also percussion, vibration, coughing techniques, respiratory muscle training, incentive method. Then is it? This is what the respiration. Next we go to the sensory motor approach. Sensory stimulation to the specific motor patterns. For example, for the coma patient, we have to do all these types of stimuli like motor, sensory, verbal, sound, visual, special sensation. This technique is proprioception, thermal, tactile. This is a proprioception. Once patient is coming out from the ventilator, patient supported sitting on the bed and wheelchair, we have to do. Then sprinting. How frequently we have to do? Every day you have to do 20 to 30 minutes per session, twice or thrice a day, at least 5 or 6 days a week. These are the special stimulus we have to do the comatose patient. Auditory, calling by their name, talking loudly, or playing music with Walkman set. Visual, torch, showing their face. We can see the some of sleep. They will take the wheelchair to the sun and they will show the sun. Olfactory. Even letting the patient smell a variety of familiar and pleasant smell. Tactile touching, you have to hold the patient hand. Gustatory, you will give some sweet or bitter taste to the tongue. What is the long-term complication? Muscle wasting. If patient has a prolonged bed movement 2-3 months, he will have wasting of the muscle. Osteoporosis, the bone will weaken. Normal cardiovascular autonomic response will be lost. For example, if you lie down for long, more than 1 week or 2 weeks, if suddenly wake up, you will have hypertension because of the loss of autonomous nervous system. Then deconditioning, pressure sore. This is how we have to do the rehabilitation. Early bed mobility, graded setting. Next slide. So this is the bed and then phase 2. Next. You have to sit up in the wheelchair, then graded walking and independent walking. Next. This is the one score, Rancho Los Amigos level of cognitive functioning. It has 10 score that we will, I think it will take the last session, I think. This evaluation stool consists of 10 levels. Progress of each patient depends on the severity, location, duration, since brain injury. Okay. The level 1 is 10 varakum. Level 1 comatose patient, level 10 is the normal patient. Next. Level 3 of the patient will have localized response. That response is inconsistent. If you do the pain, he will move the finger, but still he is coma only. Next. Confused, agitated are Next. So level 6 are confused but the patient. You should ask the patient to follow the commands. Then he has to perform his own in the home. Individually he has to perform. Otherwise, what we do is a passive process only. And it should be patient-centered. For example, paraplegia patient, you have to do some paraplegia exercise. For example, monoplegia means you have to do monoplegia exercise. For example, aphasia means you have to do speech therapy. Then you have to minimize the disease impact, facilitate the self-management evaluation. This is a team, neurosurgeon, rehabilitation consult, orthopedic service, physiotherapy service, occupational therapy, clinical psychology, and speech therapist. So these are the components we will teach the patient before going to home. And these are the assisting techniques. For example, patient having gait deformity or difficulty in walking, we should have visual clues, step over the cracks, cue cards, verbal clues. These are the assistive techniques, assistive device. Next. That is self-care, feeding, grooming, dressing, bathing, dieting. Next. Teaching remote control use, cell phone use, you should have the instrument. That is very difficult to achieve in our setup. Recent was in the traumatic brain injury include the increased use of virtual reality for the cognition and motor training and robotic devices for the early mobilization, gait training, neuromodulation technique like transcranial magnetic stimulation. So this is nothing but to improve the cognition, we are doing transcranial magnetic stimulation. We assess whether the neurons responding or patient cognitively or intelligently improve or not. Next. Another thing is a transcranial direct current stimulation. and then personalized and task-oriented therapy approach, and a growing emphasis the early intervention and multidisciplinary team management, all aimed at maximize the neuroplasticity and improve the function outcome. This is virtual reality rehabilitation. The platforms are being used to provide immersive interactive training for the cognitive function like attention, memory, execution function as well as motor skills recovery, offering highly engaging the customized therapy experience. This is robotic assisted therapy. This is for robotic assisted lower limb as well as upper limb. It is individualized, you can use it. So mainly what is the reason for means use of virtual reality for cognitive motor function, then transcranial magnetic stimulation and transcranial current stimulation and robotic assist. These four things are the used as a recent advance for the neuro rehabilitation. But we are not using that because of the cost constraint. Non-invasive brain stimulation methods like TMS and transcranial to help it think. How you are going to prevent the bed sore, how you are going to prevent the spasticity, how you are going to prevent the current stimulation, robot applicable traffic laws related to the vehicle speed, strengthen the driving license system, and ensure that all new driving licenses issued through the proper testing center. Strict compliance with the laws regarding driving under the influence of the alcohol. Strictly enforce and mandate safety devices including helmets and rear seat belt. Impose penalties for all vehicles which is not following the traffic rules. Reinforce and implement prohibition of the phones and electronic devices while driving. Strict enforcement of the prohibition of smoking in the public and private vehicles. Strictly apply blood alcohol concentration limits the new and professional drivers. Prevent the impaired driving. Enforce the maximum driving limit, minimum rest time. Limits the professional drivers. Mandate minimum age and vision requirements for all drivers. Set the laws for the safe use of auto rickshaw as well as e-rickshaw for number of drivers, number of persons in the auto rickshaw. These are the graded rehabilitation from the bed to the wheelchair, then walking, then individually should be taken. Thank you. Any questions?
Thank you so much, sir, for the enlightening session. Your insights on recent trends in TBI have provided us with a deeper understanding of the road to recovery for patients. We truly appreciate your time and expertise. We would like to extend a warm honor to our speaker. we have an engaging session on spinal cord injury rehabilitation, a crucial aspect of multidisciplinary healthcare. We are delighted to welcome Dr. Agalya Kandavelu, an esteemed consultant in neurorehabilitation, intervention science and palliative care at IGMCRI, Puducherry, with her expertise in physical medicine and rehabilitation. She has contributed significantly to improving the quality of life for patients with spinal cord injury. Today, she will be presenting as Breaking Barriers Advances in Spinal Cord Injury Rehabilitation, where she will discuss cutting-edge strategies to enhance patient recovery and functional independence. Ma'am, we are honored to have you with us. Please take the seat.
Very good morning, everyone. I am Dr. Agalya, consultant in neurorehabilitation, interventional pain and palliative care. So today we will be seeing about advances in spinal cord injury rehabilitation. Sir has already concentrated on the part of accidents and everything. So let us go. So incidence and prevalence of spinal cord injury. In US, almost 40 new cases every year they are registering. So and that's why 16 to 30 years is more prone for spinal cord injury and frequent falls. This happens mostly in case of old age. And then violence, sports injuries, these all contribute to spinal cord injury. In Tamil Nadu, almost this census was taken almost in 2014. 10 years back, it was registered as 245 cases of spinal cord injury cases are registered, and in that 88% are, as I told you before, almost 88% are male, and rest are female. So, spinal cord injury happened. You are seeing the patient. What will the patient will be asking you? There was an accident, he had an injury, and he had weakness. The patient will be asking you lots of questions because and let us ask anyone tell me what is the most common level of spinal cord injury? Where it will happen? Cervical level. So in cervical level most commonly it's in C4 C5 region, and thoracic level it's more common in T10 region, and lumbar level it's more common in L3 L4 some work or study. So after that, can they go for studies? Can they do their work? All these questions will be there. So we have to give answers for everything, which is a very difficult one. And whether the question, whether this condition will improve or not, all these questions they will be having in their mind. So there is a status data for all these things. Actually, do you know Asia scale? Okay, let me come to that later. So before that, only 2 to 3% of spinal cord injury cases recover from Asia A to Asia D by 1 year. Only 2 to 3%. But about 30 to 80% of complete tetraplegia cases, they will improve by 1 level. By complete paraplegia between T9 to T11 and 55% between T12 and below will have some recovery in the global functions within 1 year. One more thing, if the patient is having perianal sensation, that means there is more chances for recovery. Perianal sensation or pinprick sensation, it means walking, how the functions are recovering. Any idea about neuroplasticity? After the injury, the neurons are getting affected. What everything we are dealing with the neurons, no? So all these things are getting affected. By giving exercises and doing the rehabilitation, we are regenerating the neurons. So the neurons will again, by giving active training, their neurons will regenerate. This will help in their improvement in ambulation. So how will we do the rehabilitation? The first and foremost thing is, we have to identify the complications. First, we have to prevent the complications. Before treating, we should always prevent the complications. Then we have to treat the complications. And then we always have to improve the main funda will be improving the quality of life of the individual. That is our main funda, improving the quality of life. So can someone tell me what are the complications you can expect in spinal cord injury? Previously, sir was also talking about that. You were asking now, what are the complications? Pressure source, very good. Then what? Deep vein thrombosis. Then bowel and bladder incontinence. Then someone was telling from there. Something in muscle. Spasticity, yes. Anything else? Yes, atrophy. Then contractions. Then still the social integration. After that, it should be a coordination among the how many is. This is the chart. What is the main stages or states in Asia? Physiotherapists must be knowing this, no? What are the 5 states? So Asia impairment scale, it has 5. One is Asia A, B, C, D, E. So Asia A is complete loss, motor and also sensory. And B is sensory incomplete. C is motor incomplete. D is motor incomplete, where more than 50% of the key muscles will be having more than grade 3 power. So that is motor incomplete D. And E is normal. Normal means we are all walking. Do we all come under Asia E? Normal means everything normal, right? But do we come under Asia E or not? We won't. Why? Because this is only for spinal cord injury patients. Normal means from their injury, how much they are recovering. That will be the Asia. So prognosis depends on the level of injury and the strength of muscle, whether it is complete or incomplete. So medical issues and the complications. These are the very bad phases of spinal cord injury. See how the pressure ulcer is there. Look at the contracture. What is the next way? Any idea? So pressure injury is most common complication of spinal cord injury. I'll come to that X-ray later. So pressure injury is the most it's not bed sores, it's not pressure ulcer. Now it is called as pressure injury. The term has been changed. Keep this in mind. Okay. So it is a very most common cause, and it will cause sepsis and it will lead to death. And if we are not treating it properly or aggressively, it will cause lots of pain and complication for the patient. So these are the most common sites. If the patient is in the lying position, the most common site of pressure injury will be occiput, shoulder, elbow, gluteal region, heel and toes, and also ankle. Internally it will be there. So if the patient is always in the sitting position in the wheelchair, then again it will be in the head, shoulder, sacrum, ischium, because we are sitting over the ischial bone. So ischium, heel. So how will you prevent this pressure injury? Okay, 2 hours position change. Okay, this is in a bed. In a wheelchair, once in how many hours or minutes you will change? You will ask the patient to change the position. Any idea? 2 hours in bed. It's right. What about the wheelchair? So in wheelchair, so these are the types of pressure injury. There are 4 stages. Grade 1, only in the epidermis. Grade 2, little bit deeper. Grade 3, more into the dermis. Grade 4, you will be seeing bone, tendon, muscles and everything. So that is grade 4. This is one case of pressure ulcer. So this is in wheelchair. You have to ask the patient to shift the position or turn every 15 to 30 minutes. That is ideal. One should not sit in the same position always. And wheelchair we use specific cushions which will prevent the pressure ulcer. Do you guys know any name of the cushion? Foam, gel. Washer, cream. I'm talking about the cushion. Water gel. And little bit costly one cushion is there, Robo cushion. Robo. So that will also ask the patient to lie down this and all those things. This is, you have to teach the patient. And this is for bladder incontinence. We will be doing intermittent catheterization. The patient itself will be inserting the urinary catheter and take out the urine every 4 to 6 hours. For bladder we have, and bowel protein is not always bad. It gives some benefits also. What are the benefits? It helps in standing, it helps in walking, it maintains the muscle mass. Someone told that the patient will be going in for atrophy, muscle atrophy. No? If the spasticity is there, there won't be muscle wasting or atrophy. And it reduces the edema. And also one more thing, it decreases the risk of DVT. That is the more important thing. So spasticity decreases the risk of DVT. And disadvantages, and actually interfere with the activities of daily living. The positioning will be difficult, personal hygiene, and if more spasticity is there, it will lead to contractures. So all these things will become a problem. dyslexia. So it occurs in the injuries above the T6 level. Any idea what is AD? This autonomic dyslexia. In the spinal cord injury levels above T6 with pressure injury or some infection, the patient will have sudden shoot of hypertension and they will have peak, like enormous sweating. They will go in for palpitation. All those things will be there. So we have to relieve that source of it, that AD. So it may be because of bladder distension, it may be because of fecal infection or some infection in the pressure ulcer. All these things might cause AD. It can lead to cardiac arrhythmias, even death and MI. So this is a very important complication that we have to always look for. Then in respiratory system, the patient, how will you, what are the complications you can see in the respiratory system? Concussion, then? Vibration, then? What? Shaking, okay. Tapping. Do you know postural drainage? That is also more important. Based on different postures, each and every lobe of the lung will be getting drained. So you have to put the patient either upside down or sideways, and you have to do all this tapping, percussion, vibration, everything, and then so the fluid will come out. So X-ray I was showing you now. So that is called as heterotrophic ossification. If you are doing vigorous exercise, what will happen? Calcium deposits or bone, extra bone will be formed around the joint spaces. So that is called as heterotrophic ossification. When the range of motion exercise or stretching exercise, you have to always be very clear. You should not do anything aggressively. If you are doing like that, that will lead to tissue loss, tissue injury and new bone formation. That is known as heterotrophic ossification. So how will you identify that? Based on that, we will give the standard treatment. The first treatment is avoid exercise for 1 week at least. We should not touch the patient, should not touch the joint. Later, slowly we can start the exercises. We have to give some medications for that. Then we can start the exercises. This is HO. And gastro and the bowel and bladder we have. So rehabilitation of spinal cord injury. So as I told you before, the main concept is improving the quality of life. And it starts from the acute care setting and till the social reintegration. Functional outcomes to be assessed, goal setting, we have to set the goals, what this patient will be able to do. Because it depends on each and every level. Not every patient will be doing the same exact things. If it is in C7 level, the patient will be able to do only few things. If it is in T2 level, the patient will be able to do few things. So we have to know the level, assess the level, and we have to set the goals accordingly. We cannot go and tell the patients that with the C4 level injury and they are having quadriplegia that I will make the patient walk. We can never do that. But can we tell this to L4 or L3 level? L3 level patient, can we tell them, yeah, you can walk. You might walk. But in C4 we cannot tell that. Because the injury level and prognosis, it all depends on each and every level. So rehabilitation is always a team approach. There will be a PMR specialist, rehabilitation specialist, physiotherapist, occupational therapist, prosthesis and orthotist, medical social worker, clinical psychologist, vocational counselor, rehab nurse. It's always a team effort. We should always work as a team. We have to treat the patients, whatever is best for the patient. So these, like, the main thing is first we have to keep the patient properly in the bed. The proper positioning and change every 2 hours, position change every 2 hours. We have to give some splitting either. Do you know what is AFO? Okay. Orthosis, and we have to do respiratory physio. Chest physio is important. DVT prophylaxis is important. Bowel and bladder rehab is important. First we have to start with passive range of motions, then stretching and strengthening. Then strengthening exercises, endurance training, mat activities. So the main first thing is diet. So you have to give fiber-rich fruits and vegetables for the patient, so which will help them for their bowel routine, high-calorie diet, and mostly all the spinal cord injury or brain injury patients, they tend to stay only at home. They won't even go out of their bed or out of their. We should always encourage the patient to go out. In the wheelchair, we have to ask them to go out and stay in the sunlight, roam around in the wheelchair. That kind of encouraging motivation we have to give. That is very much important. Then only their function and quality of life will be improving. If they are only sitting in one room, more and more they will deteriorate. But if they are moving around, seeing these faces outside world, it will always give them some motivation to even improve. And also we have to ask them to do some meditations. There is meditation has very significant role in spinal cord healing. Always get up early. This is the morning routine and nighttime routine for the spinal cord injury patients they can follow. Get up early, eat breakfast. This is all for all of us. We can also follow. It's not. They can also follow it. And the physical training, as I told, range of motion exercises, tilt table. Have you guys used tilt table? Have you guys seen tilt table? Any idea what is tilt table? No idea? Physiotherapist? Guys have not seen tilt table? Yes, what is it? What is the use of tilt table? Okay, very good. Maintaining the posture. See, these are the range of motion exercises that you can ask the patients to do. And upper limb strengthening exercises, mat activities, exercises in the mat. These are again some few exercises. This is the tilt table. Because spinal cord injury patient or traumatic brain injury patient, they will be always lying down. We have to maintain their pressure. They should not go in for orthostatic hypotension or all these things. So gradually, 15 degree, 30 degree, 45 degree, 90 degree. Now we are standing 90 degree. From right on 15, 30, 45, and then gradually we have to increase so that the patient will be. How the patient is from down, he's kneeling down, then sitting in the wheelchair. Again, these are few transfer techniques. So walking in the parallel bar, gait training with walker, with crutches, mat activity. This is tilt table. We have to make the patient stand, and this is the, what is this called? Any idea? What is this? What is it called? Standing frame. With the support, we are making the patient stand. This kind of happens only after the tilt table. The first initial thing is tilt table. Again, standing in the parallel bar. So these are the functional abilities at different level. So see orthosis, that it will be from third to down. Then T8 to T12 we can actually ask the patient above knee AF force, L1, L2 also with the help of AF force or canes or walker we can make the patient walk. So each and every level is different. So do you know any scores for evaluating the patient? How will you evaluate the functions of the patient? How will you assess? The patient is coming, you are giving you are giving exercises for the patient, you are doing range of motion exercises, strengthening exercises. We are giving the treatment. How will we assess the treatment? Whether the patient is improving. Skill weight will be supported with the treadmill. And I'll show you all the pictures. These are just the games. See. Arm exercises, the passive and active assisted range of motion exercises will be done by the. You have to set the measure. The upper limb activities, hand activities, it will be taking care. And by virtual reality is also there. With the video games, you can make the patient do the reproduction of what are the pros and cons. Advantages are you can reproduce more activities and more than manual therapy. This is effective, but the problem is it's very costly. It's very expensive. So we can't always have a robotic therapeutic exercise machine or anything because which is very costly. And another thing is functional electrical stimulation. We will give some electrical stimulus or will place some electrodes in the muscle, which will help the patients to use their hand and move their limbs. Surface electrode, implanted electrodes. So like this. This is in case of foot drop, you can keep the electrode and then the patient will be able to walk. Functional electrical stimulation in case of upper limb. These are few exoskeletal devices that are available in abroad. Not much here in India, but in abroad it's there. And this will help the patient to walk, sit, to stand, and they can even climb stairs by wearing all these. This is a robotic device. See from the wheelchair how the patient is standing. This is a patient who is in London. By 2000, she is a paraplegia, but she is walking with the rewalk. She even contested in a marathon and all. These are the exoskeletal with some modifications. How we can accommodate the patient like that, we have to assess. There is a separate department for that. There is a vocational counselor for that. They will talk to the company or the place where the patient has already been working. They will assess the patient and then they will give some little bit, maybe not too much of work. The patient can sit and write only some entries or some system work. All those modifications will be done. And we have to concentrate about the sexual rehabilitation, home survey. Any idea about the home survey at all? That will be taken care by the occupational therapist. They will be going and seeing the house. They will see whether the doors are wide enough to fit the wheelchair. Is there any slab or anything near the bathroom? So all these things have to be assessed and it has to be modified accordingly. Okay. So even in the bathroom, whether the side rails are there near the commode, whether the seat is adjusted to the wheelchair. So all those things have to be taken care. Any occupational therapist here? Okay. So mostly occupational therapists take care of this transfer techniques, this home survey, all those things. Activities of daily living. So take home message, it's always a team effort. And we should always focus on preventing the complications than treating the complications. First, we have to prevent the complications. That is more important. And we have to taking a proper safety measure. In two-wheeler, use helmet, follow traffic rules. All those things are more important. And this is the important take-home message. We don't just add days to life. We have to add life to these. That is the main important thing. Thank you. Any doubt or any questions? Okay, I think it's time for lunch. Everyone must be hungry. Have a good day. Thank you.
Thank you, ma'am, for the informative and inspiring session. Your expertise in it has given us valuable insights into improving patient outcomes. We truly appreciate your time and contribution to this field. We would like to extend our warm honor to you. Ladies and gentlemen, it's time to pause and recharge. We now invite you to take a break and enjoy a delightful lunch. This is a wonderful opportunity to relax, refresh and connect with fellow participants. Kindly return on time before 2:30 as our afternoon session promises to be enriching and insightful. Enjoy your meal.
Jennifer.
Yes, sir.
Okay, okay. Lunch அது தெரியும். இப்போதான் சாப்பாடு பார்த்தேன் பார்த்தேன் இப்போ நான் ஜிபே பண்ணுறேங்க, அதாங்க அவங்களுக்கு நான் ஃபோனை அவங்களோட சொல்லுங்கள் எவ்வளோ அமௌண்ட் நான் போட்டுருக்கேன். ஓகே, நான் ஒரு
start the session? Everyone, please come back to your places. We are going to start the session.
Register. Today we will present on interventions for improving hand functions after stroke. Let's give a warm welcome to Dr. Shashida Rao.
Thank you very much for the introduction, and good afternoon to all. I know this is a very difficult session because your stomach is full, okay, and 2 to 3 or 2 to 4 is the period where generally we like to take little relax. So I was expecting little less participation, but it's more than my expectation, being the post-lunch sessions. So we directly go into the today's topic. So it is about interventions for improving hand functions after stroke. So this presentation is basically structured in these points. So we are first seeing what is stroke and its effect on functioning. So it will be a very brief introduction about trying to understand what exactly happens in the stroke. And also we will be primarily discussing about the best evidence-based approaches that are available for regaining hand functions after the stroke. So under these approaches, we will be talking more about mental practice. Can you please settle down? So we will be seeing about mental practice, mirror therapy, task-specific training, constraint-induced movement therapy, electrical. Hearing about this, but nothing much is practiced in India. So probably in future, and probably when you grow up or become and get hold of experience in these areas, probably you must be more seeing about these two practices. So approximately the incidence of stroke in India is around 108 to 172 cases per lakh. So this is from the latest publication in 221. Although the first author is is a Westerner, but it has more than around 15 authors, and probably all these in acute and also in the rehabilitation sector. So what is stroke? It's about it's an acute neurological disease or disorder primarily of vascular origin. So as shown in the figure, there is a disruption of the blood supply to the brain, and as a result stroke happens. And due to the disruption in the brain, the blood supply decreases. So primarily the signs and symptoms corresponds to the involvement of the focal areas of the brain. So this we know that the signs and symptoms are restricted to the extent and the site of involvement of the brain and how spontaneous recovery takes out from there. So the larger manifestation of this is that we have a hemiside paralysis, half-side paralysis of the body, and accompanied by many other dysfunctions which could be cognitive impairment, sensory impairment, visual perceptual dysfunctions, speech and language communication problems. So these are the other areas which exaggerate or contribute to the disability more. So manifestation is primarily the contralateral body paralysis, and it also includes paralysis of the trunk, face and oral and the lips. So broadly, the stroke is classified into transient, TIA, ischemic attack, and the complete stroke. The difference between these two is that in the transient ischemic attack, as shown in the figure top one, the blood circulation is occluded. I mean, they are partially obstructed. It's not completely blocked. whereas in complete stroke, the blood flow is completely blocked. So as a result, in the first one, or the transient or temporary stroke, the recovery is quick and there is a chance of recurrence of the stroke in future. Whereas in the complete stroke, we have to take an recovery is very slow and a lot of medical interventions and surgical interventions have to be done for the patient to recover. Morbidity and mortality is also equally high in complete stroke. So, one of the ways to detect the early stroke is that it is abbreviated as BFAST. That means balance could be a problem, and eye, there could be blurring of image, and it could be a face, there could be a outside dropping of the face, and also there could be a problem with the arms, and speech problem could be there. So all of this has to be addressed as quickly as possible. That indicates the time. So if a patient whoever is having or whom we come across as having these kind of problems, and if they are immediately addressed or if they are immediately given the medical treatment, the chances of recovery is much better. So it develops suddenly, the TIA develops suddenly and lasts to a few minutes to few hours, and it generally recovers by within 24 hours. So that is why it is called as transient or temporary ischemic attack. So it is caused by the pathology is the same, that because of the blood flow occlusion, there is a temporary ischemia which is developed, and due to this ischemia, the blood supply to the brain is obstructed. As a result, oxygen doesn't get supplied to the neurons, and the neurons tend to gradually die. So TIA is a warning sign of a major stroke in future, and approximately 1/3 of the TIA patient develops into another attack can be expected, and also that can also lead to the more complete stroke. So generally it is diagnosed by CT scan and the signs and symptoms which are presented. Medications are addressed towards prevention of the clotting so that the blood flow can be restored. Sometimes it is also described as ballooning. The arteries tends to balloon, and because of this, they tend to distend and weaken. As a result, the arteries will rupture, and the blood flow out of the arteries into the tissues of the brain. So that's why it is also called as hemorrhage, which is around 15% of the causes. So there is in both the situations, either it is ischemic or hemorrhagic, there is an inadequate blood flow to the brain and can result from partial or complete occlusion of the artery. So symptoms may progress in the first 72 hours as infarction, cerebral edema increases. So this is the normal response of the any type of injury. So like first there will be a rupture, and then it will be the inflammatory process which accompanies. It will be generally by edema or by accumulation of certain metabolites which are toxics. So both these increases the symptoms in the first 72 hours because edema tends to accumulate and also the metabolites tends to accumulate. And after the first 72 hours, there will be a slow reduction in the edema, and that is where we tend to see recovery in the functions. Those recovery in the functions may not be very drastic, but it can be a very gradual recovery. After that, as the blood flow and due to the medical intervention, when the oxygen supply is gradually restored, we tend to the neuron cells which are damaged, they tend to regain their function. So when the neurons tend to regain their function, that is when we see the most of the other kinds of recovery which is occurring. It could be in the form of small restoration of the body movements and also certain aspects of the speech and vision also. So there could be a gentle recovery depending upon which can have problems in the reach, grasp and releases, which could be a problem. Both of these can lead into the functional problems which result into disability, and disability in turn becomes into handicap. So when we're talking about these terms like impairment, disability and handicap, although we speak in something like as if they are synonymous, but there is a differences in their interpretation. For example, impairment is any physiological or anatomical loss which can be temporary or permanent. Okay, so here the impairment is the loss in the neurons. The neuron cells tend to try to die. So that is it can be temporary or it can be permanent. So that is the impairment. Disability is when the impairment affects the functions. How? Because of this, the spasticity and abnormal synergy, the patient is not able to function. So as a result, that is called as a disability. And when this disability, due to the impairment and disability, when the person's roles are getting affected, that means the person is not able to attend school or not able to go back to the work, not able to carry out his roles of a husband or a wife or any other roles with the play, then it is called as a handicap. So that the person is not able to visit a shopping, cannot do shopping or cannot access the transport facilities because of these things. So he is facing handicap in those nature. So there is impairment and disability and handicap, although it is a slightly older nomenclature, but is very commonly used for understanding the magnitude of the problems which the patients face. Okay, so impairment can be reverse interventions. Of course, the impairment interventions can be reversible to some extent. So the process involved in the stroke recovery is primarily can be classified as restitution, in which there is a restoration of the functionality of the damaged neural tissues. Okay, so that means when the neural tissue is completely damaged and they are slowly trying to recover. Okay, then that is called as a restoration. So or restitution. Restitution is very minimal, we can see, because we see that the nature of the taking place. Reorganization of what? Reorganization of those damaged or partially damaged nerve pathways. So when these partially damaged nerve pathways are getting reorganized, the recovery in functions can be expected. And this is primarily because of this phenomena, in the terms of rehabilitation, we are able to give our interventions. Okay? And then compensation. Compensation is the last where there is a restitution and substitution. It's all time dependent. So after a certain time, nothing much can be expected from both these phenomena. So the patient has to live with the disability. So it is where the compensation has to be becomes one of the interventions. That means instead of focusing upon the damage or the affected limbs, we have to make the patient live better with the compensation by using the normal and unaffected part. So these are the, or we can say the neural mechanisms or the phenomena by which our rehabilitation or neurorehabilitation is based on. So what is that? All approaches involve some amount of brain plasticity. The previous presenter also spoken about the brain plasticity. So during the brain plasticity, it is one of the can be understood as the ability of the brain to learn and adapt in spite of the damage. So that is our that is called as the brain plasticity. Brain plasticity is present right from our birth. When we say that we are learning something new, for example, we are learning to catch a ball, we are learning to feed ourselves, we are learning to drive a bicycle or a car, or we are learning academic related learning. All these are happening due to the plasticity, we can say, where the brain is trying to adapt. The neurons are trying to adapt the new experiences. And by adapting, they are trying to learn a new skill. Okay? So, brain plasticity, we can say it is nothing but adaptation of the neural tissues. So it helps in spontaneous recovery and it helps in the relearning of the processes. Because remember, due to stroke, the patient has lost his function which he used to do earlier. So somewhere in the brain, the patterns are there. but it has been temporarily lost because those particular nerve pathways or neurons are no more functional. Okay, so due to this phenomena of brain neuroplasticity, we can expect them to regain some of the functions. So based upon these brain plasticity, these traditional approaches or common approaches which we are familiar with, conventional therapy, we all know is of the stroke includes positioning of the patient, improving the range of motion, prevent contractures, encourage, facilitate movement, strengthening, active and passive mobilization. So these are considered as the traditional approaches or conventional approaches. So we have seen these things, like the figures which we see is some of the entity based or Bovar based approaches. So what is, when we talk about entity or Bovar based control, develops in a hierarchical fashion. So what is a hierarchical fashion? Then there is a cortical center, there are brainstem, there are midbrain level. So each one of these levels better. Midbrain level, the right-wing mechanisms are controlled by it. Brainstem level, the distribution of tone in the body are controlled by it. Spinal, the primitive mass movement patterns are controlled by it. That either the entire limb will go into flexion or the entire limb will go into extension. So these are the mass primitive patterns. So how these, it is hypothesized that the brain is arranged in hierarchy and each center has its own unique functions. And once, when we grow, we are moving from spinal to midbrain, spinal to brainstem to midbrain to cortical level. Once we achieve this cortical level control, we have all these postural reflex mechanisms. So these postural reflex mechanisms help us to maintain our upright position, maintain our sitting position, help us to move, and help us to extend our arm. So these are all voluntary control which are based upon the normal postural reflex mechanism. So this says that when there is a stroke happening, the brainstem level, the cortical level uses higher reflex mechanisms. So once you develop the higher reflex mechanism, the lower centers will automatically correct themselves. Okay. So based upon that, the treatment approaches are based. So what does this say? That the philosophy behind that is normal tone is required for normal postural mechanisms, and that will encourage the normal movement. That means you and me have normal tone. Because of we have normal tone, we are able to have the normal postural reflex mechanism. What is that? If I am tilting to the right, I can regain my balance back. If something, if I have to bend, I can maintain my head and trunk in proper alignment without giving up to the gravity. So this is the right-wing mechanism which is helping my body to control. So normal tone is what is enabling the normal postural reflex mechanism. And this normal postural reflex mechanism help us to execute the movement. Because if I am reaching forward, it is on the basis of the balance which I am having in the midline structure. My head is stable, my trunk is stable, and then a chair or a plank or a cot. So on that we tend to develop the postural reflex mechanism, and gradually as this normal tone and normal postural reflex mechanism develop, then normal movement patterns can be expected. So that is based upon that theory. So all this entity is based upon the hierarchical system, and so is your PNF, and so is our Bredstorm approaches also. Before we go into how effective is this entity, because entity is almost like say, if I am correct, more than 70-80 years old. Okay, so before we know how effective is this entity, we need to understand the evidence-based practice. Okay, so this is a very quick and brief outline of what is evidence-based practice. So as we see that evidence is collected from research. Okay, so you do research, you tend to find out and collect data, and based upon the data you tend to form an opinion. So in what all forms the data is collected? The data can be collected in simple case studies, one case reports. It can be collected on a group of cases, 2 or 3 people. It can be collected on an observation. It can be collected on quasi-experimental approach. Okay, it can be collected on random controlled trials.
So these are the hierarchy. The more up you go, the more stronger is your research or the evidence, and any result based upon that will give you a strong confidence that whatever approach you're following is correct. So when you read research paper, so any research which is coming from higher levels, the results of that will be more influential and more important for you to determine the practice. So what happens with the NDT? So unfortunately, in several reviews of NDT versus other treatment approaches, the reviewers concluded that NDT was not superior to any other types of interventions. So this is a several reviews. Several reviews means what? The authors would have gone through most of the researches, say for example from 1990 to 2020. So in that period, how many of them are published using NDT as an approach? Okay, this means that although there is not much strong evidence for the practice of NDT, because there is not much research which says that practicing NDT will give a good result, but I would not recommend you to just fold it and throw it into the dustbin. Okay, why I am saying that is because there will be some section of the people who will still benefit from them. When we talk about research, we are talking about the average response. So average is middle. There will be some people who are below it and some people who are above it. So when we talk about research, we are talking about a band which is in the middle range. So these researchers are based upon that middle range. So although we can say that this may not be very strong or very helpful in all the cases, but still there will be some patients who might benefit from these kind of approaches. But at the back of our mind, we need to keep that this is not the only approach or only research-related approach which we have to deliver to the patient. So what does it give us? We need to see that as a therapist, we need to see that for which patient, what kind of therapy will be beneficial. Okay, we cannot say that because I know one technique, I need to apply to everybody. Okay, that kind of approach, this evidence-based practice will try to check that. The tendency of the therapist to practice know whatever they know. So that is based upon the NDT, which we say that it is derived from the motor control theories. Then we have some other theories which are guiding the intervention. What are those other theories? That is, one is the neural plasticity and the other is the motor learning. So these two principles guide the more recent approaches which have been found to be more effective. So what is neuroplasticity? It is the ability of the brain to adapt, to reorganize, and by doing so it modifies the neural connections. Neural connections are nothing but synapses. So one axon will synapse with the dendrites, another axon will synapse with another dendrite of some other neuron. So in that way the reorganization of the brain takes place. How this reorganization is taking place? So CNS repairs itself by means of physiological responses and also to the shape and renew itself by responses to the practice activities. So what we're saying here is same thing, right? The moment we practice more of the activities, the neural plasticity will be developing. Just imagine that when we are trying to learn bicycle or when we are trying to learn making a tea, okay? The process of making the tea, the patterns and the cognitive things which are happening, or when we are trying to learn a bicycle, all this is establishing a new neural pathway that we can say is the function of your neural plasticity. Okay? So for that it is important for the person to practice that activity. The more you practice, the more stronger will be the pathways. So it is important that repeated practice is essential for developing the neural plasticity. So how does it relate to my therapy? My therapy says that repeated practice for the patient is also required. You and me can learn a particular motor activity by doing maybe 5 or 10 times. But a patient is not having a normal neurons. There are some neurons which are gone. There are only some other neurons which are trying to compensate the lost function. So he or she has to practice more for the neuroplasticity to help him out. Okay? And also it will be, environment will be helping them. So we need to set up. So motor learning is another, as we see there are two theories which are helping. One is the neural plasticity and the other is the motor learning. So, and your trainer was giving you verbal feedback. So that means external feedback was happening there. Okay. So in order to do that, learn the how to ride bicycle, you were dependent upon the external feedback and the cognitive process of what to do. Okay. Pressing the pedal, holding the bike, holding the handle steady. Right? These are the things we're focusing. Next stage, what happens? After few days of learning, some neural pathways are developed. Okay, you go and sleep and come back, you learn better strategies. So some neural pathways are developed. At that time, you see that you are more efficient. Maybe it would have taken 2 or 3 practice sessions. You are more efficient. At that time, what is happening? Your trainer is not no more with you. He has left you. Okay, and now you are relying on your internal mechanisms. Your proprioception, you are looking at the road ahead. You are trying to feel your body by the sensory information what is giving. So you know that your knee is going up, your foot is going down, or a handle is so and so position. You are trying to sense by internal feedback. So what transfer is taking place? From external feedback, you are going into an internal feedback. Okay? From more cognitive, where your efficiency was less, because you are focusing on how to do it. You are trying to fall, you are trying to regain the balance. So all this is happening. When in the second phase, what is happening is your efficiency is improving because you are relying more upon your internal feedback. Okay? And from there, what happens is the third stage comes where you are no more dependent upon this internal feedback, and it is something like an automatic phase which is happening. So at that time, you are able to think something new. You are no more concentrating on your bicycle. You are able to think, okay, what my mother has said at my home, or whom I am going to meet forward. So all this, or if any obstacle is coming, how I am going to overcome that. So they're thinking about all the future things which are likely to take place. So your attention is completely diverted. So you see that drastic change. The first stage of cognitive, your attention was fully onto the task. But in the last stage, you are no more attending upon driving. You are no more attending upon pedaling the bicycle. You are focusing on something new. So these are the 3 stages of motor learning, which is called as cognitive stage, associative stage, and automatic stage. So cognitive stage is something where you are trying to know what to do. Associative stage is you are trying to get the feedback from internal, and autonomous stage is something you are doing it automatically, and you are focusing your attention on something else. So this is how typically we learn motor learning. Be it driving, be it making a tea, or making a bed, or even brushing. So whatever motor activity is done, it follows the motor learning stage, which is proposed by Fitz and Bosner in 1967. So these motor learning stages are used in rehabilitation. So if I have to apply this Fitz and Bosner stage, I need to see my patient, can he please silence, please. See, you speak there, but it creates a lot of noise because the room is silent. Give instructions, use the feedback, and make them practice again and again so that they remember the motor patterns. So based upon this, some of the approaches which have been developed are task-oriented approaches. So what is that? It enables the client to move and the patient may be able to recover. So you see the complete drastic change depending upon what is guiding you. If you guide by the hierarchical theory, you will follow entity. If you are guided by the motor learning theories, you will follow the task-oriented approaches. So it is important, it should be the real objects, and the patient should be able to solve the problems whatever is facing. So again, So task-specific training is upper limb motor training draws inspiration from the principles of motor learning and neuroplasticity. A technique known as task-specific training has been developed, which focuses on repetitive and intensiveness, goal directed, it should be meaningful to the patient, and it should be having different levels of difficulty so that the patient can adapt. So this is the same thing which we have discussed upon when we are trying to ride a bicycle. All these things have been discussed earlier. So this is from the reference of that particular which has been given out. So in reference to the, as you see in the figure, the task there is to develop pouring of liquid from one container to the other. Now for a stroke patient this becomes an extremely important task, okay, because of coordination or even to perform simple aerial activity. So if you get the motor learning and neural plasticity, you know what is to be done. The therapist is making note of where the problem lies. So it is important to identify the problem. Is it the grip, nose, stacking cones? It says that those things all are not required. You focus on the tasks which are meaningful, which are purposeful to the patient. So it should be patient-centered and it should be also cognitive related. So it uses the real-life tasks and like pen manipulation, cutlery manipulation, picking up a cup and etc. So practices are given in those areas. So what is important to realize here is when stroke happens, the functions are lost in every area. The patient finds difficulty in performing all the activities of daily living. So under such situations, what is the task which I have to focus? So this is where the client-centered approach comes. So you ask the patient, sit with the patient and see, identify the top 5 things which you want to do. So in the top 5 things, do the task analysis. See that while performing the task, where is the problem lying? Which step, that component. When you are doing task analysis, you are doing the component analysis. So once the tasks and components are identified, try to give them repeated practice on. So it doesn't claim that you retrain the patient in all the activities, or it doesn't say that once you apply this approach, the patient will be independent as he was in earlier stage. It's a very task-specific approach. That's it. So that some of the who all can benefit from this. Now, as I said earlier, there are some multiple therapies which have been available to us. Now we need to see that which therapy will be applicable or more relevant to which patient. Okay, so there will be some criteria. If you apply the criteria, your outcomes will be much better. So to apply task-related, task-specific therapy approaches, we need to see that they should have minimum of active extension of the wrist and fingers. So this is the important criteria. If the patient doesn't have this, then your task-specific approach will not be successful. So you may have to go something down, something neurodevelopmental or brainstorm or things like that. And you should allow for multiple of the repetitions to take place. Now the second therapy which we discussed is the constraint-induced movement therapy. So it is very popular nowadays, and again here what is happening is the patient can relearn the motor movement. The patient can relearn the motor movement by restricting the use of the non-paratic arm. Non-paratic arm means the unaffected arm, the normal arm. So what is saying, the task specific is saying is you use the affected arm. Here they are saying, here they are saying that the unaffected arm, your constraint induced will not work. To enable for the constraint induced, at least there has to be some, according to brainstorm stages, stage 4 or 5 will be much better. Okay, so in that way we can try to apply them into more useful way. So here, constraint induced involves 4 components. One is it should be task specific and repetitive in nature. It should be so repetitive that around 3 to 6 hours per day. So imagine the patient has to perform that movement, the task, almost 3 to 6 hours per day. Okay, then only they are saying the motor pathways or the neural pathways will relearn the motor patterns. There has to be shaping or coaching, 1:1. So that means the therapist will be constantly identifying where the mistake is and trying to rectify this mistake. The third is the most important. Third, it says that a restraint should be there for 90% of the waking day. That means the 90% of the wake hours, the patient has to wear the mitt, which is a very difficult thing to achieve. We will not get a cooperation from the patient. Imagine 90% of the time you are blocking the normal hand and you are asking them to use the affected hand. Okay? So if the patient is motivated enough and if he is having those minimum activities, minimum abilities, then the constraint use can be very useful as the research indicates. So because it was the duration is very big for 90 hours of the day, minimum 2 hours per day for 5 days a week for approximately 3 weeks to 6 weeks. So this is the duration which is being indicated. Because it was getting very difficult from the therapist also to administer this, they have modified the approach. That is called as the modified CIMP. What is happening in the modified is they are trying to come up with some lesser intensity than the previous one. So the CIMP is more intense. Okay, these are little less intense. Low intensity is just half an hour to 3 hours per day of practice. High intensity is 3 to 6 hours per day without with practice. So what is the evidence says in this? The evidence of using CIMP says that it improves the movement of the use of the affected hand and promotes neuroplasticity of the brain as seen. So how this can happen? Okay, but this has been used since ages. Okay, how particularly when we observe someone doing, we learn certain motor patterns. Okay, it is used in learning musical skills. It is used in sports. Mental practice is helping. What is the basis of this approach? The basis of this approach is something rests on the mirror neurons. So we have seen motor neurons. We have heard about sensory neurons. Now there is something called mirror neurons. They are not new. They have been discovered many more than 70-80 decades before. Motor, when we again learn them, and through sensation also. So there are two types of motor imagery, which is internal imagery and the external imagery. So probably the last one, the external imagery, they are trying to imagine how the movement pattern will look like. Okay, all in coaches, maybe those of us who have learned the cricket or badminton, the coach will ask you to imagine how the movement will be, how you are going to strike a ball. All imaginary, right? So that is the external imagery. So these are some of the neurophysiological basis of how mental practice will be using it. So mental practice theories, it is debated whether mental practice relies on cognitive, motor or motivational practice, and it is more about learning simple tasks, and imaginary abilities may vary, and the task learned must be more meaningful to the patient. So something like folding the clothes, these all can be practiced through mental imagery. It is any meaningful task. So so and so Page and the group of researchers investigated the efficacy of the mental practice in increasing the function and use of the affected upper limb of 11 patients, randomized control trials, and they have found that tasks like this ADL task can be retrained by these approaches. So evidence practice says that 21 chronic patients who had received 10-week program of mental practice emphasizing upper extremity use during valued activities before, immediately, and 3 months after intervention. There seemed to be more carrying over effect is there of the therapy. Then comes the mirror therapy. Again, same philosophy of mirror neurons, and also about the the neural plasticity and motor learning. Okay, so what is happening here is this was first developed for treating patients with amputees who are experiencing phantom pain. Phantom pain is the sensation, abnormal sensation of experiencing the limb being present and being very painful when it is actually not into that, the affected hand. The other side of the mirror is the normal hand. The patient does movements from the normal hand and sees in the mirror. So it gives a false impression to the brain that the affected hand is moving. You getting it? So he puts an affected hand through the hole and sees the image of the normal hand on the mirror, and he moves the normal hand and sees that and feels that the affected hand is moving. Okay, so that is the mirror therapy. Developed for amputees, seen to be more useful for stroke patients also. So the affected hand is put behind the mirror and the unaffected hand is in the front of the mirror. Different activities and exercises are performed moving the unaffected hand and arm. The patient watch and the movements in the affected side. So this is just an illusion which has been created. Okay, so that illusion helps to regain the function. So it also stimulates the mirror neurons and so this can be used to improve the sensory functions of the affected side. So what are the prerequisites for using the mirror therapy is any stroke who has either one-side paralysis or general weakness after stroke, no visual or perceptual impairments, endurance to participate in up to 30 minutes activity, and have a positive effect on the arm, function, sensation, and neck length. So now these are the electrical nerve stimulation. So as I said, it is as of now we are in a stage of saying wow, that impressive, think it is going to happen nice. So there are various kind of electrical nerve stimulations which are being given, and they are found to be more effective also. So we don't have any first-hand experience of using them in stroke patients, but there are various TENS can be used. Physiotherapists might be knowing the TENS. It is the same modality which is used to treat pain conditions that can be used even for stroke. So studies of electrical stimulation delivered to the peripheral nerve system have not delivered any positive results. Cochrane review shows that there is for central nervous system there is some better results are there. Then comes the visual reality, which is slowly picking up. We are almost towards the end of the presentation. Visual reality is there, which we see more in normal. People are also using it, and the same thing can be used for training stroke patients also. These are even morning 2-3 presenters have spoke about these concepts, and they are found to be very effective nowadays. So this is one such phase which they have been indicated. So in conclusion, we can say that a variety of techniques and devices are used by rehabilitation therapists to treat patients with upper extremity dysfunctions, which includes NDT-based approaches, task-specific, constraint-induced mental practice, mirror therapy, and all to one degree or another being shown to improve upper extremity functions after stroke. In general, research indicates that training should start as early as possible and be intensive, repetitive, and task-oriented. I think the bottom line is very important. It says that training should begin as early as possible, so that we can, because the neural activity, it is fastest during the first 3 months, then it slowly tapers up to 2 years. Beyond that, plasticity is there, but it's at a very slow rate, which is not going to be very effective. So with this we conclude, and any questions are there?
O for an insightful presentation. The practical approaches to improving hand function post-stroke will certainly enhance our clinical practice. We would like to extend our warm honor to our speaker. Our next speaker is Professor Dr. K. Naresh Babu, OT, MSc in Psychology, FAOT and PhD. Dr. Naresh Babu is the Dean and Principal of Sri Abhinami College of Occupational Therapy. Today he will speak about MNRI, Makastuba Svetlana Neuromuscular Reflex Integration. Please welcome Dr. Naresh Babu.
Thank you all. I think after your heavy lunch, you are in the sleeping mode, I know. Hopefully my college also I am getting all the time in the last because the students will be in the posting, so I will be getting the last lecture. Hopefully I will try to make you a little better with a wonderful topic. I think everybody has spoken about all the neurons, neuroplasticity, and even the brain enlargement and whatever it is. So from the morning you might be enriched with all your brains. So we will have some kind of a little bit of work how you can able to treat within you as well as your clients. So this reflex integration, most of the time I think one of our professor, Sasidas sir, has explained about how we can able to relearn when we have an affected in your brain. But I try to make you that once sometimes it is retained or exaggerated reflexes, how we can able to unlearn the reflexes. Because unless until if you are not unlearning or maturation or inhibit those reflexes, you can't able to have a flexible. And sometimes we have to face the pain because as a physiotherapist, your way of work will be more of stretching, right? If any physiotherapists are available. And we used to do dynamic, we have neurodevelopmental therapy done by Nancy. So all I met them directly in Goa. And even for Svetlana Maskotova, she came to India to give a 5 days training. So I attended in, when I was in Singapore, I used to come for that 5 days and I attended that. I think only 55 people could be attended in that particular program. After that, it never happened in India. The most of the people who got trained, now we are actually training the other people like a trainer of trainer program, but still the licensing program is not happening in India. Hopefully it will happen soon, but it is wide famous and widely used by many people. But I used to say, even Sir knows it, everything is old wine in a new bottle. Saying it in a different words. So like same like when we say autism and Asperger, it was written by Greek. So Asperger already they are writing about it in high functioning autism, and for autism, Leo Kanner has already developed in 1942. So when they merge to have that, then we have a separate condition. So same thing here. She was actually writing in Poland, so her language, but when it got familiarized and many people were using. Before that itself we have a reflex inhibiting pattern already been popularized. But here she has developed larger number of reflexes. It's not that only what we studied, spinal reflex, brainstem reflex or a midbrain reflexes. Here she has developed those with a different pattern like motor coordination system from medial to lateral, anterior to posterior, upper to lower. So we will see each and everything in a little part, but I don't want to give you more brain teaser for you. So before that, I will want you to have one exercise, which I will give you a kind of a treatment technique through the reflexes later. Can you all able to do stand for a minute?
So if we can able to try simple exercise, which we all want to know about our hamstring strength, right? We all know about hamstring strength. So most of the time our Tendulkar used to do a lot of exercises. Even the Dhoni used to do a lot of exercises. And many cricketers you might have seen, before going for any kind of a sports, we do the warm-up exercise, right? Warm-up exercise has some kind of a countings. So for hamstring exercise, they have to do 23 times of hamstring stretch to have a proper flexibility. So what we usually do is to try to touch the toes. Can you all able to do it? You just check it. How much you can able to reach to your toes. Many people can able to touch your toes, I think, right? Those who can't able to do that have some kind of a pain. At least if you have any pain in your hamstring touch, did you any felt pain by touching it? Here, the hamstring. So for this particular hamstring stretch, we have to do 23 times of hamstring stretch. Please. So the most important stretch they used to do is, I think many people try to bend down, they try to touch the head. I can't do that. So the other people, you can see some of the even you are seeing somebody will used to do keeping the legs on the wall or in some place, and they will try to touch the head. These are the stretches which might cause some back pain for us essentially. So I am trying to do one. It looks funny, might be Bharatanatyam. 3 times I try to do this reflex, but you can able to achieve it. Still some more. These 3 reflexes can able to easily make your hamstring release from the tenophysio. So this particular reflex have a lot of changes because our fascias are integrated within these reflexes. So you know the importance how the reflexes can be more important for your everyday function. If your flexibility has to be maintained, you don't have to do many other things. For example, Sir used to tell about the task-oriented approach and task-specific training, where we also have some kind of cases like, for example, motor neuron disease or Alzheimer's disease. These are degenerative diseases where here we have to retain the energy. So most important for occupational therapy versus physiotherapy, we used to actually, we don't waste the energy. We try to channelize the energy mainly for the ADL work. We don't lose it because otherwise the patient feel that I couldn't be able to achieve that particular function. We always try to give a energy conservation and work simplification techniques to become as a optimal functioning in the everyday activities. So this same reflexes can able to reduce their energy and pain and can able to better do their functions. We'll go for the particular topic,
which we can give explanations, like little kind of glimpses about reflexes, then we can also understand the other things. The motor skill development, you know, from the utero to the standing and walking stage. So from the reflexes, how it has been integrated, the reflex mechanism, proprioceptive and vestibular cells. So TVP. So this particular senses, proprioceptive and vestibular senses, is more important to us when we work with the sensory processing disorder children. And these reflexes, when it is retained, it affects the maturation in both vestibular as well as in the proprioceptive system. You know about the reflex tract and how the reflex circuit happens. Whatever there is, for example, about the Newton invention, you know about it. When there is an action, there will be an opposite reaction or a positive reaction. But here about any stimulus, there should be a response. If there is no response, then we have a problem. So we always address, try to give a stimulus, again the stimulus, if there is a response, then we can able to achieve the pattern better. There are some dynamic postural reflexes which I have studied my certification on this particular reflexes. There are many other reflexes, but I try to categorize these reflexes into simple and complex, from central core reflexes to the peripheral limb reflexes. So in simple reflexes we have dynamic, which are spinal gallant, spinal parades and hand pulling. Nothing but the simple, the children, we try to pull their hand, how their head lagging is. And in postural reflexes, we have hand supporting and Babinkin paramental, but we might have not studied in our usual books, but in MNRI, she has mentioned about this palmomental reflexes. And in complex, we have a leg cross flexion extension, Thomas atomic crate, and Boyer crawling, and Moro embrace reflex, and flying and landing reflex. In postural reflex, we have a trunk extension, symmetrical toning reflex, asymmetrical toning neck reflex, toning labyrinthine reflex, abdominal posture, amphibian reflex, launder reflex, parallel orientation, and many other reflexes which are into the postural reflexes. And in dynamic, you have seen the Robinson hand grasp and Babinski and foot tendon gallant reflex, which is the Robinson hand grasp reflex. When you actually give a kind of a pressure near to the thumb, thenar muscles of the thumb, automatically we get a little bit of contraction over the mandibular maxillary joint. We will get a kind of a clenchness. And when we release through the end of this particular place, same pressure we give it into this index finger, then we get relaxation over there. Many people with the stress, you might have heard that clenching of their teeth during the night time, or many times with the sensory processing difficulty children. I don't use the word autism. So those children used to do the brucism. So we can able to give this kind of a pressure. We use a lot of other sensory diet techniques, which is Bellwether techniques. But here we can use this particular MMRI reflex points can able to reduce the clenchness. So these kind of reflexes with bonding as well. Bonding reflex is very much connected, but most of the reflex happens only during the consciousness. When it is no consciousness, then there is no reflex patterns or no responses. So we have, even in the coma, we need to give the stimulation to get the reflexes. So in diencephalon, we have all the connected cerebral cortex with the brainstem. And the brainstem system, we have all medialis and medulla oblongata, all the reflexes are connected. So as for the categories, they have given how we have given for the normal reflexes, we have the same for the right left LCS and upper lower LCS and front and back LCS. As you know that the three important reflexes we used to study in our syllabus. Hopefully you remember, I used to give a kind of example for APNR to be extended and the legs will be flexed and the cat can come out of it. The same reflexes happens for the child. When the child head, we are trying to flex it, automatically hands get flexed and legs get extended. This reflex is much more needed for alternative stepping or crawling movement. Unless until the crawling movement is not developed, there are lot of retained reflex which makes them to have much more motor coordination defects. Most importantly, for autism children, they used to say that they skip crawling or the creeping patterns. So many research books says in different ways, but the skipping of this particular crawling movements causes a lot of effects in the dressing skills as well as in the movement skills, the gait patterns, even in speech patterns as well, because everything is connected with the movement. So here the retained reflex for APNR, we used to say about Raman bow and arrow. So where Rama goes and even the upper body, and if it is in the prone lying, then it will be extension of the back side of the hands. And this reflexes, if it is persistent, there is a condition in cerebral palsy called opistotonus. So the opistotonus is obvious that TLR is still not integrated, which has to be the same condition in MNRI techniques. We have to give the same pressure. Sometimes we use the technique called the neutral warm technique, rolling up the wedge shape. So it was priorly being used. Now I think most of the clinics will not use this particular neutral warm pattern. But this is the same technique we try to use the key points of places to give the pressure to retain those reflexes where it is firing. And we have a asymmetric tonic neck reflex, symmetrical tonic neck reflex. Grasp reflex, I have given the child more sensitive and still keeping the legs on the toes. And there is a reflex called which we might not study in our syllabus, which is fear paralysis reflex. This is also existing in developed by Maskatova Svetlana. So she has actually developed that this fear paralysis reflex actually is due to the stress that mother is away from the child. So automatically child gets a kind of a fear. That wantingness captures the child to cry to grab the mother. So this kind of reflexes still it is difficult when they are still retaining. Then there is a breathing difficulties and feeding difficulties. And we have a moro and spinal gadget reflex and get rising reflexes. All needs to be matured for this particular assessment. What actually we do in MNRI, we try to see that whether the patterns are being matured or integrated. We do that particular kind of a testing. So there is a protocols for testing to know that whether the patterns are being already matured. So this pattern testing is more important in MNRI, which is not available in other approaches. So this particular testing itself is a treatment techniques. Sometimes what happens, that same testing method, if you do repeatedly for the same client in a same place, it becomes a treatment protocol for the same client. If you are giving the same pressure, gliding with the same movement for the particular child, the same particular gliding movement becomes the treatment technique and it solves the reflex patterns. So this is what is a specialty in MNRI techniques. Pattern, direction, strength, timing and symmetry. As pattern, does the motor response demonstrate the proper overall pattern of the reflexes? Direction, whether the direction of the movement of the motor response occurs, and strength, is the strength appropriate, whether we are applying the strength is appropriate or the child is exhibiting the response is appropriate. And we have a timing, how quickly they do respond, so the timing is more important. And symmetry, whether both the symmetry place is working, so that we can able to identify whether the asymmetric tonic neck reflex still persisting. Movement which I ask the patient to do it, so that I can able to know which phase the patient lies on and where I have to work on for that particular client. So this methodology, which will not be available in any internet or any places, only by doing the course we can able to appreciate this particular movement. The same we can able to see it in Heinz Hammersmith infant reflexes method. So here the initial pattern where the spasticity existing or the reflexes existing, the person's, and last one we have phase 8 to 12, it is related to the skills where we can able to do the multiple patterns of individual finger movements. There is the levels of Maskatova levels of integration from 0 to 20. So where we have different patterns where it is affected. So we have given it in a colorful form where we can able to identify if it is from 6 to 10, 7 the child is still existing. Most of the time we calculate in a different way. For example, the preterm child, if he borns at the age of 7th month, for example, it's a premature child. So we have to calculate that pattern as well. So still it has not been developed, but we might be thinking the child born. From the born itself, we will calculate the 9 months or 8 months. But actually we minus those particular things. Like it is up to 10 months. From that we calculate the chronological age. So the reflex maturation happens in the same way. It's not like whether the child is born, most of the time when Kutava does it, we experience. I don't know whether we can experience now. But when she does it, she usually try to do it in our hand itself. We can able to feel the clench on the particular joint, and even it stimulates the saliva. But I don't know whether after that we tried a lot, not happening, but might be a magic. But she explained in a video also in a very nice manner that the particular place of giving the pressure in a proper depth pressure, we can stimulate that clenching activity or the relaxation activity. These are the medialis, lateralis sites of motor coordination reflexes. I have already given it with the pictures. Robinson's hands grasp, ATNR and STNR, and hands pulling and Babinski developmental reflexes. And for these are the chronological ages when it has been matured. So we can able to plot it according to the birth months, not according to the real chronological age. These are the body upper lower, superior inferior MCS, where we have automatic Thomas reflexes, Boyer crawling, parallel orientation, lauder reflex and flying and lauding reflexes, and hand supporting reflexes. These are the chronological ages of reflex development, the same for MCS. And for anterior posterior MCS reflex, we have a spinal talent, spinal teres, and STNR and TLR. And we have a trunk extension reflexes, which has to be matured for them to have a crawling. So this happens from anterior to posterior motor coordination system. And this is the chronological reflex development. Happier for the autism children, because whatever you do repetitiveness in a particular rotation also, they will be happier. They can get a more pressure. So the same kind of like cigarette smoking. It is a repeated do. It's not actually they are enjoying the cigarette smoking. They are doing the same task repetitively to enjoy. So when we try to reintegrate that reflexes, they can able to further or withdraw from those kind of repetitive actions like even alcohol abuse or other drug abuse. We can able to solve this problem. That's what he has developed a kind of a reflex integration patterns. Even she used to tell about some of the reflexes about shoulder pain, back pain, and other osteoarthritis and other pains, where through the reflexes she can able to relieve the pain and they can able to better function within a second in a magical way. So try to learn that and try to give a glimpses about it. Thank you very much for listening, and hopefully
Thank you, Dr. Naresh Babu, for that fascinating talk on MNRI and its application in social reflex integration. We would like to extend a warm honor to our speaker. We will now take a short tea break. Products made from Rehabilitation Center are being displayed for sale. You can take a look at it. Please be back by 10 minutes.
Kind attention, please. Kindly gather for taking group.
everyone.
அவ்வளோதான். Decide and decide.
சரி கிளம்புறீங்களா?
Now we extend our warm honor for the staff from Sai Apollo Institution of Nursing, Vaibur and Panduti for brought up 41 students as volunteers to the program. College Coimbatore. Is there anyone?
Welcome back everyone. For our final session, we have Ms. J. Jennifer Joy, MSc in Psychology and Assistant Professor at PYAIOTA College for Women. Ms. Joy will present a talk on modern psych rehabilitation, a timely topic given in the growing awareness of mental health in rehabilitation. Let's welcome Ms. Jennifer Joy.
So hello everyone. I know it's a final session, it's all to concentrate, but I will make it short and clear. So I'm going to talk about psychology. As everyone over here have some knowledge and have been touched about psychology. So everyone knows that rehabilitation works on psychology. But particularly I have to know why psychology is needed in rehabilitation. Why we need to prioritize psychology in rehabilitation. What would be the reason? Can anyone answer me? Why we need psychology in rehabilitation? Can anybody answer it? Why psychology in rehabilitation? Why? Can anybody? There is no right and wrong. I need to know your perception about psychology. From it. He never going to try any treatment that he's going to give, or he never going to trust you as a therapist, and he never follow your treatment plan. So what would be the reason? The result will be zero. There is no result. Even though you put your 100% in your treatment plan, even though you put your 100% energy on the patient and mind, but at the end, and emotion, and also I mentioned that psyche. It's a short term where psychology is developed. So psyche is human mind, and we constantly believe that every human behavior has a need. All human behavior க்கு பின்னாடியும் ஒரு need இருக்கு. So and the need எப்ப end ஆகுதோ அப்ப என்ன ஆகும்? The human behavior or the human will be end, dead. So there is a need, there is a survival, there is a lifelong searching and drive. So that's how psychology works. So based on the need, pleasure, human behavior, form and sustain. And also I mentioned, when we are talking about human behavior, we can't omit some people in psychology, like even Pablo, J.P. Watson, or Abraham, and also we have Sigmund Freud. So they are the pillars of psychology. They gave a foundation and they talked about behavior, they talked about mind. When there is a period, no one talks about psychology. So every behavior has its own belief. So next, rehabilitation. So what rehabilitation psychology do? So not only the rehabilitation, when we are going to restructure a human behavior, or when you are going to build a trust, belief with your client or patient, you have to go through clinical psychology, health psychology and rehabilitation psychology. These three elements play an important role in rehabilitation. So what rehabilitation psychology do? So it's an emotional coping, mental and psychological status, and also it helps to assess a standardized assessment tools, and it will help you to know what you are really going to do, what you are really going to work on. So what is the part you need to work on? So if a human behavior is formed, it has three major layers behind it. Like if I do a certain behavior, for example, if I am smoking, so smoking is my behavior. So behind this behavior, I have a thought. Behind the thought, I have a emotion. Behind that emotion, I have a pleasure. So when I am going to talk to someone, I am telling them, no, you should not smoke. Stop smoking. Smoking is not a good habit. It will cause bad effects to your health. Any communication directly to them to change their behavior. So that's how it works. Next, body and mind connection. As I said, our body is like a, and body, the relationship of mind and body, and how it works, how it's interrelated to others. So, I am talking about the modern techniques, and the most modern and somewhere some practice and not in more practice biofeedback. So biofeedback is nothing but it will track the physical changes you go through when you have a mental changes. Like if you are undergoing stress, your body will have more physical changes, like changes in the heart rates, changes in your voice tone, changes in your body temperatures or sudden changes in the environment, and it will record your normal breathing rate and changes in the breathing rate if you have stress or anxiety. So when you see these changes and also practicing relaxation, you can able to come the changes in a normal way. And also when coming to brain waves, we use biofeedback by using EEG. So with EEG, you can monitor brain waves by the pads we placed on the brain, and it will help you to monitor your wakefulness, sleep, and also your brain activities. And also we have a heart rate recorders which we using ECG. So with ECG, you can monitor your heart rates and the changes of heart rate in under different kind of situation, and will help you to monitor it. And like this for muscle activity, blood glands and temperatures. So for everything we are going to do that. So mental practice. I want everyone to close your notepads, pen, put your phone on silent mode. Just I don't want to do the same thing again and again, giving your lecture, giving your information. We'll just close from now. So just sit straight. Just come to this event, come to the workshop, focus here. Don't think about anything. Don't think about anything. Just close your eyes. Close your eyes. Just hear what I say and just follow it. That's it. Don't think about anything. Relax. Relax. Okay, so all of you have heard this somewhere in your syllabus, which is called guided imaginary technique. So we are going to do that. So just relax and follow my instruction. So I'm starting now. So we are going to travel in a forest. So we are going inside the forest. It is very big forest and it is your own forest. You can imagine anything you want. You can imagine trees, flowers, river, grass, animals, and you can hear the sound of water next to you and a smell of flowers, and you can see a colorful flowers, a big trees, animals running, and you can also see a swing there. So you're slowly going next to the tree and seeing the swing. You sit on the swing and you started playing the swing. You can take 50 seconds to enjoy this swing. Then you can see there is a basket near the tree. You're getting out of that swing and you walking towards that basket. You're taking that basket and you're taking that basket and walking to your right, and you saw flowers. A beautiful flowers in the plants, and you see each flowers in a different color, and different smell. You can able to smell it. You can able to touch it, feel it. With beautiful fishes over there, and you going close to the water. You are touching that water. You can feel the rush of gentleness in that water. And also you are seeing your reflection, your face, your facial features. And you are admiring it. And you stand up. Slowly started walking into the forest. You saw a group of rabbits and 2 peacock dancing over there. And another big tree. You can take your time. You will be having 1 minute. After this 1 minute, you are getting out of this forest. So you can go and explore the forest you created as your imagination. You can imagine any. So we have started walking back. Keep that basket. Where you put that basket under the tree. You just keep the basket there. And see around the forest. And we started getting back. We are leaving that forest. Again we saw a river, the tree, the grass, the flowers, the animals. We are slowly coming out from the forest. We are slowly coming out. We almost out. 3, 2, 1. You can open your eyes. You can open your eyes. Slowly. So much of information, so much of resource, information overload. So just relax. We are therapists. So yes, we are going to treat so much of patients' minds. We are going to take care of so many people's mental health. We are going to handle so many people's vulnerability, illness, disabilities. So we are just like the most safest person in the world. We should be very safest person. We should be the yield hara. We should be the most inspiring, motivated, presentable person in the world. Because we are going to work with so much vulnerable people in the world. So how it start? When we start healing ourselves, when we start taking care of ourselves, when we start healing our own dramas. So when I want to treat someone, when I want to take care of my patient or take care of my mind, I should be take care of myself first. I should be prepare myself as a therapist. I should heal my own drama. I should be physically, mentally fit. So when that will happen, who will guilt to give a time for relaxation? Who feel guilt to give a pass? Relax. Go slow. Take it slow. Everything is going to be happen. Just give a pass. Relax. Prioritize yourself. This will happen. If this theory part will happen, you have a great professors all over college. They will teach you. But apart from over this classrooms, prioritize yourself. That what I used to tell to my students when I sit there and observe everyone, I
thought like telling this to you all. So just prioritize yourself. I don't want to make you to be the complete perfect person. No one is complete perfect person. But be that peaceful person. Be that healing person. So you guys have that aura to heal someone. We all have that aura. We are healers. So when we can call us healers, we heal our own past traumas, personal life. So that was the main thing. And also this theoretical knowledge. Thank you so much.
Thank you, Ms. Jennifer, for sharing your knowledge on modern site rehabilitation.
அண்ணா இந்த டியூப் லைட்டை போடும்.
We request Devanamma College student to gather on stage. We request PPG College of Occupational Therapy students to gather on stage.
போயிட்டு எல்லா புக்கையும் எடுத்துக்கலாம். அங்கேருந்து புக்கு ஆர்டிசம் புக்கு எல்லாத்தையும் தூக்கிட்டு அதை அவனை கூட்டுன்னு போய் தூக்கிட்டு வந்துடும் சீக்கிரம்.
We request Dr. P. Punyamurthy sir to come on to the stage. And students of Annai College of Occupational Therapy to gather on stage. And now we are honored to have Dr. G.R. Satyavan, BOD, MSc Psychology, MD in AC, Executive Member coming to stage to deliver out of thanks on behalf of all of us.
அனைவருக்கும் வணக்கம். So, very good evening to Canada. So, this is very important moment for all of us. நன்றி மறப்பது நன்றன்று, நன்றல்லது நன்றி மறப்பது நன்றி. ஸோ இந்த குரலுக்கு ஏற்ற மாதிரி நன்றின்றது ரொம்ப முக்கியம். எல்லாருக்கும் நான் சொல்ல அனுபவிச்சிருக்கேன். So, we extend our sincere thanks to all our government officials who have allowed to conduct this seminar and express our gratitude to our respected speaker, Selvam sir, who came as a chief guest to this event. So, மெயினாக நம்மளுடைய ஸ்டூடெண்ட்ஸ்க்கு முக்கியமாக நன்றி நான் சொல்லியாகணும். ஏன்னா இன்னைக்கு சண்டே எல்லாரும் வேலையை விட்டுட்டு என்ஜாய் பண்ணுவீங்க, எக்ஸாம்ஸ் போயிட்டு ஸ்டடீஸ் எல்லாத்தையும் விட்டுட்டு இந்த செமினாருக்காக வந்துருக்கீங்க. ஸோ என்னுடைய நெஞ்சார்ந்த நன்றி PPT காலேஜ் ஆஃப் ஆக்குபேஷன் தெரப்பி, கவர்மெண்ட் காலேஜ் ஆஃப் ஆக்குபேஷன் தெரப்பி, அன்னை காலேஜ் ஆஃப் ஆக்குபேஷன் தெரப்பி, ஸ்ரீ லக்ஷ்மி நாராயணா காலேஜ் ஆஃப் ஃபிசியோதெரப்பி, சாய் அப்போலோ இன்ஸ்டியூட் ஆஃப் நர்சிங், பண்ருட்டி அண்ட் வேப்பூர், தெய்வானி அம்மாள் காலேஜ் ஆஃப் சைக்காலஜி அண்ட் ஆர்டிடியூட் இன்ஸ்டியூட் ஆஃப் அலைட். ஸோ இந்த எல்லா காலேஜுக்கும் ஸ்டூடெண்ட்ஸ் ஆகிய நீங்கள் வந்திருந்து இந்த ஒரு செமினாரை ரொம்ப சிறப்பாக நடத்தி கொடுத்துருக்கீங்க. அடையாள அவர்களுக்கு எனது இந்தியாவில் நன்றி. நெக்ஸ்ட் இந்த செமினார் வந்து ரொம்ப யூஸ்ஃபுல்லாக இருந்துச்சுன்னு நினைக்கிறேன். அதுக்கு மிக முக்கியமான காரணம் நம்மளுடைய டாக்டர்ஸ், ப்ரொஃபஸர்ஸ். ஸோ அவங்க உங்களுக்கான தியரிட்டிக்கல் பயிற்சி நல்லா கொடுத்துருப்பாங்க. ஸோ டாக்டர் சத்யமூர்த்தி, டாக்டர் சரவணன் சார், டாக்டர் தனசேகரன், டாக்டர் அகல்யா சங்கரன், டாக்டர் சசிதர்ராவ், டாக்டர் நரேஷ் பாபு அண்ட் மிஸ்டர் ஜெனிஃபர் சார்ஸ். ஸோ எல்லாரும் உங்களுக்கு ரொம்ப சிறப்பான பயிற்சி கொடுத்துருப்பாங்க. அது வந்து யூஸ்ஃபுல்லாக இருக்குன்னு நினைக்கிறேன். ஸோ அந்த எல்லா மருத்துவர் ப்ரொஃபஸருக்கும் எனது நெஞ்சார்ந்த நன்றி தெரிவித்துக் கொள்கிறேன். அடுத்தபடியாக இந்த செமினாரை எடுத்து நடத்திய பாலிசியம் சாப்டர் ஆஃப் ஆல் இந்தியா அசோசியேஷன், ஆக்குபேஷன் தெரப்பி அசோசியேஷன். ஸோ இந்த அசோசியேஷன் வந்து ரொம்ப நாளாக பல ஸ்டெப் எடுத்துகிட்டு இருக்காங்க. அங்கே ஒரு செமினார் வந்து ஒரு நல்ல விதமாக கொடுக்கணும் அப்படின்னு முயற்சி பண்ணியிருக்காங்க. அதுக்கு முன்னெடுத்த டாக்டர் இளவரசன் மற்றும் அசோசியேஷனில் இருக்கும் மக்களோட அனைவருக்கும் எனது நன்றி தெரிவித்துக் கொள்கிறேன். இது சிறப்பாக நடப்பதற்கு ஆத்திச்சொலி மற்றும் அரிச்சொலி ஊழியர்கள், இந்த மருத்துவமனை ஊழியர்கள் அனைவரும் நமக்கு பல உதவிகள் பண்ணியிருக்காங்க. ஸோ நெக்ஸ்ட் இது எல்லாமே ஒரு வரலாறு ரொம்ப முக்கியன்ற மாதிரி ஹிஸ்டரியை கிரியேட் பண்ணுது.
Certificate will be shortly issued.
கீழே வந்துருமா, கீழே வந்துடும் உள்ள வாங்குறோம். கீழே வந்துருமா, ஒன்றே தான். இல்லை அவங்க பிளாக் இந்த ப்ளூ பக்கத்தில் இருக்குங்க. ஃப்ரண்ட் பக்கம் அவன் மறையிறாங்க. ஓகே. அவங்கள அரேஞ்ச் பண்ணி வச்சு